I don't see them. Maybe they are in the exhibition corners. We have PEPFAR. Anybody from PEPFAR? PEPFAR? Our partners, majority of them have not yet come. We have Uganda AIDS Commission. Anybody from Uganda AIDS Commission? Aha. Oh, the Uganda AIDS Commission are the majority so far. Thank you so much for organizing this and for, keeping the fire of the fight against HIV AIDS burning. We thank you so much. We also have TASO. TASO members, anybody from TASO? Aha, TASO, thank you very much and thanks for the exhibition. We have Amical members or representatives? Not here yet. We have EGPAF. Perhaps they are in the exhibition place as well. Then we have the Makerere University School of Public Health. Makerere University School of Public Health, I saw your name on the list. We have UNASO. I want to thank all of you, and I also want to kindly invite all of us to thank the USC Board Chair, Dr. Eddie Mukoyo is here with us. Dr. Eddie, thank you very much for helping to organize this. We have Dr. Sam Mukware, who is the ED of Uganda National Health Science Research Organization, my very old friend from Ministry of Health. Thank you very much, Dr. Kware, for being strong and keeping the fire burning. I want to also recognize, I know some of them I'm going to invite here shortly, but let's recognize them all. Dr. Dennis Tindiebwa, who is going to be our chair this morning. You're most welcome. Thank you so much. Dr. Elizabeth Ekirapa from School of Public Health, thank you very much. Thanks a lot. We also have a representative of the Uganda AIDS Commission, representing the Director General, Dr. Nelson Musoba, who is not with us here, but Dr. Vincent Bagambe. Dr. Vincent Bagambe, most welcome. We are now going to start our discussion, ladies and gentlemen, and I'm going to start by inviting our chair of the first session. Let me invite Dr. Dennis Tindiebwa, the plenary chair. He is from Aneka, and he will be accompanied by Dr. Elizabeth Echirapa from Makerere University School of Public Health, who will be his co-chair to come and start us off so that we can catch up with time. You're most welcome, ladies and gentlemen. Let's give them a clap. Let's energize them as they come up here. And let's now listen to them as we go towards the next presentation. You're most welcome.
Thank you, MC. Good morning, colleagues. Good morning, friends. I want to welcome you all to this session. I want to thank you for braving the traffic and the sudden change of venue. And we want to start our session now. I hope you have seen the program that was shared by the co-MC earlier on. So I would want to invite the board chair of Uganda AIDS Commission, Dr. Eddie Mukoyo to lead us in the opening session. I know Dr. Mukoyo way back, many years back. He's now the chair of the board of Uganda AIDS Commission. But really, for me, what I know of him was a dedicated district health officer, and I've always challenged him to publish the innovations that he did when he was a DHO, and I'm hoping that he will tell us, although this is not part of the AIDS Symposium. But I also know he's one of the people who started DIHS2 way back, many years back, and now we know how useful this is. So, Eddie, please, you are most welcome.
Thank you very much, Session Chair, and for your kind remarks. The Uganda AIDS Commission board members, and I want to request one of our board members to stand up for recognition. Commissioner Charles, representing the youth. The development partners that are present, you can stand up for recognition. I think they're on their way. Members of the scientific community, including Dr. Sam Okware, those of you who've been in this space, you know him very well. People living with the HIV constituency members that are present, civil society partners, implementing partners, the media fraternity, our online participants, distinguished ladies and gentlemen. I'm glad to welcome you all to our dear key stakeholders to this National HIV/AIDS Symposium. Uganda AIDS Commission conducts joint annual AIDS reviews of the implementation of the National HIV and AIDS Strategic Plan to fulfill its mandate of coordination, monitoring, and strategic information management for the response, including national and international reporting obligations. The 2023 Joint Annual AIDS Review and the Symposium mark the third year of reporting on the National HIV/AIDS Strategic Plan. This year, the JA has been organized as a symposium that features the following: the National HIV/AIDS Exhibition, that will create an opportunity to showcase the country's achievement in addressing HIV and AIDS. 2, the National Scientific Meeting, which is an important platform for sharing research findings for an evidence-based HIV/AIDS programming. 3, commemoration of the Fidel Retired Day through a lecture in remembrance of the heroes who left a legacy in advocating for openness and disclosure amidst high burden of HIV-related stigma and discrimination at the time. 4, the HIV/AIDS Financing Dialogue. This year's National HIV/AIDS Symposium will build on the previous one held in November 2022. The collaboration with research, academia, and science has been enhanced through research, academia, and science and professional bodies self-coordinating entity. The theme of the symposium. The symposium will run under the theme, My Responsibility Towards Ending AIDS by 2030. The theme is intended to call on every individual to take personal responsibility and action to protect and care for themselves and their loved ones in the fight against HIV and AIDS. The purpose of this symposium is to share achievements, lessons learned, and progress towards the country's targets and goals of ending AIDS. Specific objectives are to review performance of the national HIV/AIDS response during the third year of the National Strategic Plan 2020-21 to 2024-25, to share evidence from the latest HIV/AIDS research studies and implementation science, to showcase best practices and innovation in delivery of HIV/AIDS services so as to inspire individuals to take action, to commemorate the Fidel Retire Memorial Day, to strengthen domestic resource mobilization as a sustainable way of ending AIDS. The expected outcome will be an AIDS memoir with clear recommendations and undertakings for implementation during the 4th year of the National HIV/AIDS Strategic Plan. I wish you fruitful deliberations for God and my country.
Thank you, Chair, Board of Uganda AIDS Commission. And now we like to go into the real session, the first one of the listening to the Joint AIDS Review Report. And this is going to be given by the Director General of Uganda AIDS Commission, represented by Dr. Vincent Bagambe. Vincent, you're welcome.
Thank you very much, Mr. Chairman. Ladies and gentlemen, allow me to ride on the protocol that has been established by my boss and save time, and also not to make a mistake of not recognizing some of you here. And yet all of us are important. I'm waiting for IT to... Thank you. So, ladies and gentlemen, I have the pleasure to present to you the National Joint AIDS Review Report on behalf of the Director General of Uganda AIDS Commission. My names are Dr. Vincent Bagambe. I'm trying to learn. Okay. So the presentation outline, we will be two people presenting this report. I'll take you through the introduction. I'll give a brief status of the HIV epidemic and how we are progressing on attaining the 95. And I will also look at, I will look at so I will look at the monitoring and evaluation of the response and maybe a few of the issues forward. So, ladies and gentlemen, each year we conduct an HIV and AIDS review. It's jointly done. It's done by Uganda AIDS Commission convening with the stakeholders. And this is based on the National HIV and AIDS Strategic Plan, which we developed together some 3 years back. So for the year 2023, we looked at the progress in the implementation of the NSP for 2022-2023 up to June, but also it coincided with the review of the 7th year of the Presidential Fast Track Initiative. As you are aware, His Excellency the President committed to the people of the Republic of Uganda that by 2030, we will have ended AIDS. It also coincides with the 8th year of the Sustainable Development Goals. So So our report comprehensively reviews and sees where we are at this point in time in regard to those three. We will also review progress on the progress on implementation of undertakings, which we agreed on to last year at MOBS on the same event like this one that we'll be able to implement in the year that has just ended, and perhaps agree on the undertakings for this year. To develop this report rather, we set up multi-sectoral teams, and so Uganda AIDS Commission just took the lead. But all of you, your organizations were represented on this team. We reviewed documents, we looked at secondary data, and also we did stakeholder consultations. In addition to this, we were able to compile quarterly reports that we've been receiving from self-coordinating entities. And all this consolidated into one is what we are presenting to you as the report. Still struggling with technology. I might need TA here. Okay, so we were lucky that as we were compiling this report, we had a rich niche of documents. We had just conducted the midterm review report, which we have with us, which looked at the implementation of the, progress on implementing the NSP from June 2020 up to December 2022. We also had other documents. We have the Global AIDS Monitoring Report, which we've been compiling also on annual basis. We have the National HIV and AIDS Estimates. We have a new report on HIV modes of transmission, which also came out in 2023, and the population size estimates for adolescents and young women at high risk of HIV in Uganda. So all these documents made it easy for us to do a document review and have this report that we are sharing with you today. So based on that, we came up with a report, and as I said, I'll share with you the performance. Let me start with the impact indicators. If you look at the HIV incidence, when we developed the National Strategic Plan, our baseline was at 0.32%. And we set a target to reduce this to 0.2%. Our review for this year shows that we are at 0.22%, meaning that we are remaining with a 0.02% to hit our target. So in that regard of incidence, we are on track. We are also on track to reduce the prevalence. We were at 5.5 at the baseline, and we have already attained 5.1%. However, for the other impact indicators, new HIV infections, we wanted to bend the curve from 5.4 down to, 54,000 down to 18,000 by 2025. So halfway, or rather more than halfway down the road, we are still seeing an estimated 51,000 Ugandans getting infected. This, of course, raises a concern of whether we'll be able to bend the curve enough by 2025 to attain our target of 18,000. For the HIV-exposed infants testing, HIV positive at 6 weeks, We had a target of reducing it from 2.1 to 1.3 by 2025. We are now at 1.4%. You could say, oh, you are remaining with a 0.1 percentage to hit your target. But this has been a stagnant indicator. We are not, we have not yet attained elimination stage for mother-to-child transmission of HIV. And then the last indicator in that category, annual HIV-related death, annual AIDS-related death. Our target was that we reduce it to 10,000 from the 21,000 where it was in 2020, but we are still at 17,000. So this is also a stagnant indicator. Ladies and gentlemen, the report also shows that the estimated number of people living with HIV in Uganda is 1,430,000 or thereabout. Next slide. The other indicator I want you to pay attention to is our progress in attaining the 95-95-95. When we developed this strategic plan, we looked at what do we need to change in order for us to attain end of AIDS by 2030. And this is one of the indicators that we are closely monitoring. I would say that at baseline in 2020, we were at 90% of people living with HIV and AIDS in Uganda, knowing their positive HIV status. And of those, we had 91% already on treatment, and we had, I can't read that figure, but as you are seeing it on the screen. However, in 2023, the percentage of Ugandans who are living with HIV and AIDS who know their status has just increased by 1 percentage point, and we are at 90%. And of those who know their status, those who are actually on treatment have increased to 94%, and those who are on treatment that are virally suppressed are at also 94%. This figure may give you a sense that we will attain 95-95-95 by 2025, but unfortunately, when you disaggregate these bars by age, adults and children, then you realize that actually the children and adolescents are being left behind. They are nowhere near or close to going to the 95-95-95. Next slide. I will also give a brief update on the Presidential Fast Track Initiative achievements. As I said at the start, His Excellency the President made a commitment, not only to Ugandans, but also to the international community. And we said that for us to end AIDS, we need to work on 5 pillars. Pillar number 1 is around prevention, that we engage men, so that we end new HIV infections in young people, especially the adolescents and young women. So in this regard, we are distributing condoms so that people can have protected sex. This year we distributed 141 million condoms, but unfortunately it was a reduction compared to what we distributed last year. We have been able to reach 617,000 adolescent girls and young women with packages that help them to live a more comprehensive and protected life. We are seeing more cases of violence against women being reported. There were about 140,000, and also the packages that we give to young people who are in school, we've reached 40 schools, and we were able to reach about 20,000 young people. In terms of progress towards eliminating maternal to child HIV transmission, we unfortunately are continuing to see some children or some mothers who are unable to protect their children. We see pass-through infections, especially for pregnant mothers who are newly infected with HIV, and of course those who are not adhering to their medication. In terms of care and treatment, as you heard, we are at 90, 94, 94, instead of 95, 95, 95. Then resourcing of the response, we had wanted that by 2025, the domestic resources are covering 40% of the costs of the response. Right now, government contribution has increased from 13% to 14%. Last year alone, government of Uganda spent 358 billion funding the response. But I would say we needed 2 trillion. So that is still a drop in the ocean. We have come up with a strategy to further increase domestic resources, and we think that we'll be able to improve, but I'm not so sure that we will achieve our target by 2025. And last but not least, in terms of effective coordination of the response, there are a number of interventions that we've been able to do, including having community-led monitoring arrangements, including engaging districts, ministries, and departments to ensure that they have functional coordination structures and that they report on the interventions that they are implementing. But also, we have come up with an accreditation system which we think will help us to further improve on how we manage and coordinate HIV by the non-state contributors. We have also had activities relating to capacity building, especially at the regional referral hospitals and the other health facilities. Then my other slide is relating to implementation of the JAR 2022 undertakings. Ladies and gentlemen, as I said earlier, when we were at Nakawa MOBS, we agreed on 31 undertakings across the various thematic areas of the strategic plan, which we were to prioritize and implement in this year. I am happy to report that out of the 31 interventions that we had prioritized, we implemented fully 25 interventions, and therefore 6 interventions were either partially implemented or not implemented at all. And the list of those which have not been implemented is there. I think my technical team will be sharing this slide so that those who are interested in knowing where we are not doing well can follow up. But also in the detailed report, then we have the interventions that we were able to fully implement, those that we had prioritized. This is my last slide, and then I will invite my colleague, Dr. Peter Wakoba, to give detailed achievements per thematic area. So what are the key issues as we look forward to 2023, 24, 2024, 25? We are seeing declining performance in behavior and structural indicators, and this really needs to be addressed. We are seeing persistent mother-to-child transmission breakthrough infections, as I said earlier, and unless we cross those taps, then we will not attain elimination status. We are seeing children and adolescents lagging behind towards attaining 95, 95, 95. Also, significant community level viral non-suppression is still ongoing, as evidenced by the non-reducing new HIV infections, especially amongst adolescent girls and young women. We are also seeing structural barriers, stubbornly refusing to go. We are seeing we still have stigma and discrimination, gender-based violence, legal issues, and others. I don't know if the stopping of the screening means that I've used up all my time. If you could please put back the last slide. Thank you. We are also seeing a lack of unique identifier as one reason we are failing to attain the quality of data that we would want. And of course, we have a paucity of data regarding behavior and structural indicators. And what you can't measure, you can't manage. So we need really to work towards ensuring that we have sufficient data for adolescent girls and young women interventions as well as GBV. And of course, suboptimal data utilization at subnational level. And last but not least is the inadequate financing from domestic sources. So for now, thank you for listening to me, and allow me to invite my colleague, Dr. Peter Wakoba, to take you through the achievements by thematic areas. Thank you. So this one should be going to the next slide.
Apologies. Thank you. I'm called Dr. Peter Wakoba. I work with the Uganda AIDS Commission as head monitoring and evaluation. I've also been a DHO before, and I'm also a gynecologist. So I'm just going to go through the achievements per thematic area. You know very well that the NSP has 4 thematic areas. That is prevention, care and treatment, social support and protection, and then system strengthening. And then we'll also have a component of monitoring and evaluation because of its importance in the response. Next. I'm not going to follow that because the first slides were presented by my boss, Dr. Bagambe, so I'll go directly to the thematic areas. Kindly go to prevention there. That's the first thematic area, and it has 4 objectives. And we shall talk about each of them briefly. The first objective talks mainly about behavior and structural interventions for HIV and AIDS response. So we have had initiatives which have been implemented, and we think these are causing a dent to the epidemic. For example, we have the Education Plus. This is an intervention which is aimed at having mainly behavior. The behavior, you know, in the beginning we didn't have drugs, and so the response was mainly on the behavior interventions and trying to keep children in school so that the knowledge improves. They have better knowledge and understanding of the HIV response, the prevention intervention, so that they are able to reduce on the risk, the risks which are associated with the increased HIV transmission. Then the integration of HIV and AIDS in the curriculum for training for lower classes. Then we have, of course, you know, the condom programming has come a long way, and every year there is improvement. So we have a 3-year strategic initiative on condom stewardship launched, and then, of course, the last mile delivery of the condoms. You know, the response, like I believe, is not here, it's in the community. And therefore, the more we move the services closer to the communities, the better. Then, of course, the legal environment. We've had 2 reports published about the legal environment. You know, in order for everybody, for equity, for everybody to access the services, then we need to mitigate the legal environment to ensure that the services reach to everybody, irrespective of his or her affiliation in a social network. Then, of course, you know very well that the First Lady of the President of the nation has been at the forefront for the fight, supporting the fight HIV and AIDS, especially in the adolescent girls and young women. And this is a good, it shows the political commitment and the understanding of the response by our leaders. We also have safe male circumcision. Of course, you know that this is a good technology studied in Uganda, implemented here. When well done, combined together with the other interventions, we shall have a dent on the epidemic. Next. Now, we know very well that the adolescent girls and young women, actually, if you look at the segregation, they bear the highest number of new infections, contributing to about 36%. So there are interventions that are targeting them in particular, because that is where new infections are happening, and definitely they will be transmitted to even older people. So some of the interventions, though not scaled up completely, but eventually I think we shall be able to roll out to the whole country. Therefore, we have some interventions which are targeting those the population. We have also a problem. There is a violence prevention and response, provision of school subsidies to keep the children in school. Then the Journey Plus, this is mainly aimed at providing information and services to the young population. Of course, the biggest challenge is we are talking about maybe 44 high burden districts, but then that is not enough. We need to reach out to everybody. Then we have declining use of condoms. This could be due to stockouts. And then, of course, the adolescent young girls and women interventions are fragmented. We are in high burden districts, but you know, we shouldn't say that the rest of the districts maybe are not high burden. We should leave them out. We are brewing something. We need to go full scale and cover the whole country. Let's continue. Next. Now, this is HTS. To summarize this, the good result is that we tested more people, but even after testing more people, the positivity rate is slightly lower than what it was last financial year. That's what those 2 graphs are talking about. The one on the left, my left, which could be your right, is talking about an increment from 5.9 to about 6.8. I think that's because of the many types of testing approaches that we have, which were not there, and scale, taking them up to scale. Next. PMTCT, the coverage has improved. We have about 98% of mothers who are pregnant on ART, but we have a problem with the retention up to 12 months that we need to address. And then among those who are on treatment, we have about 93% who are suppressed. And then the early infant, AIDs, early infant diagnosis within the first 2 months is about 86%, and the positivity rate is 1.4. That speaks to what Dr. Bagambe was talking about. We still have a number of children who are contracting HIV from the mothers. That's what, and then the key challenges, then we have breakthrough infections during the cascade, low testing, retesting in pregnancy. When mothers come for antenatal, the first visit, they are normally tested. But then I think we take it for granted that when you test negative, then everything is okay. But you know that you can seroconvert during the pregnancy. So the retesting rates are not very good, 31%. Then retention, when you look at the different age categories, the young mothers are poorly retained on treatment. And then, of course, this is coupled with the unmet need. If you know the 5 prongs of PMTCT, family planning is in there, then the unmet needs of family planning in the general population also affects those who are pregnant. And then ARVs prophylaxis, HEI is the HIV-exposed infants is stagnating at 81%. We need to go to scale to 100%. Next. Pre-exposure prophylaxis, it has been scaled up to about to 702 sites, reaching up to about 1 million. Those graphs show that as the years go, I didn't tell you that this is the 3rd year of implementation of the NSP. So we tried as much as possible to show that trends. The 1st year of implementation of the NSP, the 2nd year, and this is the 3rd year. But you see progressively we are improving, we are capturing more, we are accrediting more facilities, we are reaching more sites. And the last one, I don't have a pointer, but over there, it shows that the population which is utilizing this intervention mostly, those are sex workers at 44%, and their clients at 15.8%. So some of the new interventions we have adopted and trying to roll them out, we have the ring, the pivoting ring, and then the injectable Kabla, that is a cabotegravir. This will scaled up, but we have issues much as we are utilizing. The utilization is still low, and then the linkage to services is still also low. And then, of course, retention. We can look at it in a different way. Why there's no retention? Maybe people, I won't say it, but let's continue. KP, key populations programming. We cannot hide about this, and you know very well the AHA law. Since it's being passed, of course, it affects even when you go to the village, you know, you find that everybody has his own interpretation and the way this affects the service utilization. So the Ministry of Health have gone ahead, the Ministry of Health has gone ahead and tried to mitigate. So we have the adaptation strategy, try to mitigate the the effects of the law. Then there is a framework for all the KP activities which is being implemented. Capacity building on human rights. Of course, here we are talking mainly about the legal environment and how services can reach to everybody. Then, reaching to different populations, we have an expanded peer-led drug distribution outreach. Then, the key indicators for measuring performance of key populations interventions have been refined. Coming from the M&E background, for us we believe that if you don't measure, if you cannot measure it, then you did not do it, and this the information that we need in order to program well for this population. So we refined the indicators and we are able to collect some of the data. Then, of course, there's high prevalence of HIV among women who inject drugs at 24%. What are some of the key things that we have done? The first medically assisted therapy center, it operates in Butabika, and there is a plan to open another one in Mbale to serve the population. Then 10 drop-in centers. DIC is not disseminated in vascular coagulation. Drop-in centers. That is one of after the AHA law, because of the fear, the DICs, the drop-in centers, some of them closed, thinking that. Thank you very much. Let's continue. Social behavior. By the way, the biggest thematic area is prevention. It touches everywhere, and of course, you know very well that prevention is better than cure. So that's why I'm taking a little bit of time, but the next thematic area will be more straightforward. Then social behavior change and communication is the last objective, and we recognize the efforts of the First Lady in all the campaigns that she has been leading. We have the Time Up campaign, then we have the Education Plus, and then the different interventions, also that specific interventions like provision of subsidies to keep children, girls in school, the adolescent girls and young women population subgroup, which are specifically targeted because of the high levels, the high numbers of new infections. Let's continue. Care and treatment is the second thematic area. We have the ART coverage improved in the year under review. And to note that the biggest population, which is 96.1%, and first line, second line is 3.7%. And this is a good thing when you have more people on first line drug. First line, that's better, because the higher the line of drug, then they are more expensive and more toxic. The viral load suppression, like Dr. Bagambe presented, we're at 94%. And then we also have about 1.4 people, 1.4 million people on ARVs. That leaves about 300 people who we should target and initiate on treatment. Let's continue. This pharmacovigilance and supply chain management, we have not had high incidences of ARVs stockouts. And then we have sentinel sites, which are targeting adverse effects, and these are well studied. The details, by the way, I didn't tell you, you can refer to this book. Most of these things are here, so that at your free time, you can cross-check with the facts there. We have also reviewed the HMIS tools for collecting routine data. And of course, special evaluation was done about 6 centers about the toxicity of DTG being a new drug which was the last introduced, and it was found that it is not of concern. Let's continue. TB integration. Now, because of integration, you cannot talk about HIV without talking about TB. Definitely, this has improved over time. The results do speak for themselves. Patients with TB are screened for HIV, and those with HIV are screened for TB, and then appropriate actions are taken in order to ensure that we treat both. Let's continue. Gaps. We have there are some supply gaps. We have some stockouts and testing kits. You mobilize so many people, but then the kits may not be enough. Then limited availability and access to newer diagnostic technologies at lower health facilities where you have to ship samples to the centers, and then factoring in, you find that the turnaround time for the results takes some time, and this may affect service delivery. Then, of course, we have issues of retention and issues of viral load suppression, especially in the children, which we need to take care of. Let's continue. Social support and protection. What have we done? We have done a legal assessment, like I mentioned before. We have an adaptation strategy to mitigate the effects of this law to ensure universal provision of services. Then we have developed stigma and discrimination guidelines and the implementation framework to monitor this, because if we don't fight stigma and discrimination, then we really have a problem, because it negatively impacts on service provision. Let's continue. Yeah, these are some of the services which are provided to the people living or affected with HIV, and this can be read. This can be revised in the booklet. We have those vulnerable populations provided with the services to keep them in school, economic activities which are being encouraged among adolescent young girls and women, so that we can cross-check. Let's continue. Gender-based violence, of course, this negatively impacts on HIV service provision, including increasing the risk of HIV transmission. So a few things, we have done a few things that we need to scale up. The sexual violence rates remain high, which means we are not doing enough. Domestic violence also has increased. And then, of course, we note that females are more affected than men, so that makes them even more at risk of HIV new infections among that population because of the conditions in which they are leading. The key issue here is the reporting is not harmonized. We have fragmented NGOs, okay, we have some police, but then all these reporting mechanisms are not harmonized. So what we are talking about may not be a complete picture because of the different and fragmented reporting mechanisms. Let's continue. Yeah, the legal, we've touched it here and there, but of course, the legal environment affects service provision. Some populations, because of maybe being stigmatized, may not get the services, yet they are at risk because of what they do. So this whole thing of legal environment and the framework for implementation of the services need to be reviewed. Yes, we have We have a desk at USC, recruited a senior medical officer there to look into these issues and improve on the framework for implementation of HIV and AIDS response amongst the key populations to reach to scale. So we are on the right direction to this. Let's continue. System strengthening. Yes, delivery of HIV/AIDS interventions, you cannot do that if you have weak systems, and the weak systems enable you to deliver on all the pillars, the thematic areas, let it be HIV prevention, let it be care and treatment, social support and protection, even monitoring and evaluation. We need a good background of systems, and systems are being classified into, that's leadership, governance and leadership. We look at infrastructure, we look at human resource, we look at resources for provision of services, all the three thematic areas, and therefore, and then management of logistics. Let's continue, I'll talk about it later. What I need to say is that the funding is mainly donor dependent, and all what we are doing is trying to ensure that we have all discussions about sustainability. How can we sustain the HIV response in all the three aspects, not only in financing, but also in leadership, leadership and systems. How can we sustain the response when we have the physical, the real amount of money is reducing. So the gap there, we have about 70. Of course, when you look, there has been just a slight increase in the funding. The gap has it remains at 700 million US dollars. I don't know, convert that in Uganda shillings, but that's lots of money in order for us to meet the projections that we had in developing the NSP to reach out to everybody. Let's continue. Monitoring and evaluation. This we cannot go without talking about it. So we have revitalized the USC engagements and improved governance and leadership at national and subnational levels. At national levels, Dr. Bagambe talked about the president taking the lead in the PFTI. All the ministries, departments, and agencies have coordination structures to coordinate their response at that level. Then at the districts, we also have district coordination structures, which help in coordinating the response. And we also have, at community level, of course, we have community-led monitoring, which has strengthened community networks, enhanced service delivery, and client outcomes. I think in order to adequately provide services, we need to address the gaps in the community systems so that all the services reach the last mile. Those I've talked about. The AIDS Trust Fund, we talk about every year, but because of the financial management laws here, it does not, yes, it was passed in the HIV and AIDS law, but maybe we shall not go for it because of if we establish the HIV and AIDS trust fund, then maybe somebody will want the diarrhea fund or something. So what are we focusing on? For now, we are focusing on mainstreaming, HIV mainstreaming, so that HIV is not implemented as a parallel program. But once we integrate, then we are able to address, using the limited resources, we address the gaps in the intervention. This has been a synthesis, and I don't want to go into it. The AHA law, you know the excitement which is there everywhere at all levels. And this could dent the success that we are pursuing. It could impede our attainment of an HIV-free generation by 2030. So we have provided a synthesis of how we can approach in terms of mitigating the negative effects which this law could have on the HIV and AIDS response. And I don't want to go in detail about it. We can read about this is an abridged version, but we'll have a full-blown report, which is about 100 pages, and we can look at it. And arising from this, we can have an undertaking which we can follow up during the next joint AIDS review. Let me stop here and thank you for listening.
Thank you. We allowed a little more time because we realized you needed a lot to cover all those themes for thematic areas. But nonetheless, I think we will recover some time. At this juncture, I want to hand over to my co-chair, Professor Elizabeth Chirapa, to take on the next part of the session.
Thank you. Okay, thank you. So once again, we are all aware that the theme is my responsibility in ending this epidemic. So I want to ask you, what is your responsibility? Are you playing your role? So if you are a young person, are you playing your role? If you're a middle-aged person, are you playing your role? From the looks on your face, I'm not so certain that all of us are playing our roles. And so we'll try and help you a bit. We have a few people whom we are going to invite as panelists to share the wealth of experience that they have with us. And I want to begin by inviting Ms. Kcca Namwanje to come and join us over here. Kcca is the Executive Director for Acts 101. That is not the Acts that was in the Bible. That's a 2023 Acts. Kcca, you're most welcome. I also want to invite Dr. Edward Kato, who is the Community Health Lead in the AIDS Control Program at the Uganda Ministry of Health. Dr. Eddie, you're welcome to join us at the top here. I would also like to invite Dr. Anthony Lwegaba. Dr. Anthony is a retired medical officer who used to work with Brackeye. He's now a lecturer at the University of West Indies. Anthony, I hope you are with us. Edward, I'm not seeing you. Dr. Watiti was not there some time back. I don't know if he has now arrived. Dr. Stephen Watiti, if you can hear my voice, we are looking forward to seeing you. Please do join us at the front, those whom I have called. So Dr. Anthony Lwegaba, and then Dr. Eddie Kato, and Dr. Stephen Watiti. So I'd like to begin by posing a question to Ms. Kcca. In the presentation, we had that adolescents and young people are being left behind, and yet they certainly do have a role in ending this pandemic. So where are we getting it right as we deal with young people and adolescents? And where do we need to step up our efforts? Could you just share your thoughts with us?
Thank you so much. I think where we are doing well would be engaging young people and building capacities. I think as a country we are really trying to build capacities of young people. That is information, services, even capacities for them to engage in such forums. To be able to speak on behalf of other young people. I think that is one area where we are doing well. One area where I think we need to really do better is to allow young people lead in the designing and implementation of programs, most especially those programs that are designed for us as young people. If we are talking about service delivery, how do we get ARVs to young people to actually access them, adhere to them? If that is one of the issues. I saw the article recently in the newspapers. How about we redesign the issues around access? Young people want to access services from areas that are most convenient because we are having challenges at the health facility. So how about we reimagine, maybe at the pharmacy, maybe community safe spaces. We need to reimagine how we get services to young people, and I think the best way to get that information is from young people themselves. So as we are designing these programs, we need to make sure that young people are at the forefront, telling you what we want.
Okay, all right, thank you so much. So I also have a question for Dr. Edward Kato, but I think he's not yet up here with us. You are here, okay? I saw somebody else earlier on. So Dr. Edward, you're welcome. So you are one of the people who are spearheading the community health work. And we are aware that in the decentralized service delivery model, we are aiming at bringing these services closer to the community. There are a few areas where we've had that we are struggling when it comes to retention among those who are on the prevention of the mother-to-child program, when it comes to linkage to care for the key populations, when it comes to retention of those people who've been enrolled on those PrEP programs as well. What does the DSD service delivery model offer for these groups?
Thank you so much. I had prepared a presentation. I don't know whether I'm allowed to present it.
Could you just get closer to the mic?
Okay, thank you so much. Good morning, everyone. I had prepared a presentation. I don't know whether I'm allowed to present it. 5 minutes?
Okay. So it's 5 minutes. Don't make it the African 5 minutes. 5 minutes in Africa could be 20 minutes.
I'll make sure I take 3 minutes. Good morning, everyone. My name is Edward Kato. I'm representing Ivan Alinaitwe, the DSD coordinator. And I'll run through the presentation very fast, looking at our current performance in terms of the 395's cascade, DSD implementation, and the next steps. But since the two previous presenters have talked about how we are doing around the 395s, I'm going to skip that. But the major focus here is that more new infections, the data shows that it's among young girls 15 to 19 and 20 to 24. I'll skip this, but the take home is we are not doing well in terms of viral suppression among the children and adolescents, but my next slides will try to show what we are doing in differentiating care for them so that we can improve their outcomes. Okay, for the new people who are interacting with the word DSD, it refers to the various ways we are providing HIV prevention, care and treatment services that are tailored to the needs and preferences of people living with HIV so that we maintain good clinical outcomes and improving efficiency. So we look at client-centered care and also improving healthcare efficiency. In 2017, when we started DSD, we started with 5 models, and we were directing patients where can you get services from, and how do you get services from? How do you get the services? But last year, with the guidance from WHO, we opened up the differentiated service delivery models to having group-based models and individual models, and clients can determine where they want to get served depending on where they are coming from, what is the problem they are having, and how best can they interact with healthcare workers to address their problems. So this is the breakdown of the different DSD approaches we have in the country, and the number of patients that are in the different approaches. But we see that 65% of the patients in the country are in the less intensive models, which is good that they do not take more than 5 minutes to access services. And the 35% is the one that are in the high intensive models, meaning they take a time interacting with the healthcare worker to address their issues. So in a bid to improve service delivery further, we introduced what we call the community retail pharmacy drug distribution point, commonly known as the community pharmacy. And I know most of the PLHIVs who are seated here are on this model. It was designed to improve client experience, reduce waiting times, and reduce health facility congestion by using private pharmacies as dispensing arms of the health facilities. So currently we have close to 45,000 people living with HIV who are able to get their drugs in private pharmacies across the country without going to the health facility where they have to line up in long queues to get services. This slide is trying to address our gaps. The past 2 presenters talked about non-suppression, the third 95, and the challenges we have among children. So this slide shows the striking correlation between non-suppression and undiagnosed, and you can see that wherever there is a non-suppressed client in the first map, it shows that you can find someone who is HIV positive but is not on treatment. So we are in a bid to achieve the third 95. We are using what we call the integrated service delivery model to ensure that we reach the non-suppressed, and they also link us to the undiagnosed or the sexual contacts who can be tested and started on treatment. Yeah, so this model I'm talking about aims at integrating service delivery at community and at household level to microplan for the most vulnerable individuals, promote person-centered care, and improve efficiencies. So these vulnerable individuals we are talking about are the children, are the non-suppressed, are the pregnant and breastfeeding women who we are failing to retain in care, who we were failing to achieve optimal viral load coverage and suppression. So we have moved to the community to ensure that we provide care, so that with the aim of preventing and breaking the chain of transmission, addressing morbidity and mortality, and strengthening the social services support and linkage to livelihood opportunities. So in this model, we identify where these vulnerable communities are and attach them to community health workers so that they address service delivery gaps at household level, and then we track outcomes at facility level. So this is part of the package we provide. It's peer-led, as you see, that when we attach a community health worker, they are providing this package at community level in a household where they do treatment literacy and health education. They follow up the pregnant women and the children for viral load bleeding, for clinical appointments, for psychosocial support and directly observed treatment and support, AHD screening and referral, and linkage to social livelihood opportunities in the community. So in terms of the next step in improving service delivery, we are piloting integration of other services in community model, such as NCDs, family planning and PrEP, so that when a client comes for their ART, they are able to receive family planning and also their NCD medicine, so that they do not need to make a route to the facility for NCD or family planning, and then to the DSD model for ART. So we are integrating them so that we improve care. And then number two, strengthen support systems for DSD implementation through scaling up the integrated service delivery model, and also performance review into quarterly, and integrating DSD performance review into quarterly performances of the region, as well as carrying out client satisfaction surveys on the different DSD approaches so that we can get feedback from the clients on what is working and what is not working better to improve service delivery. Thank you. I'll stop here.
Thank you so much, Dr. Kato, for sharing that with us. I now have the privilege of inviting Dr. Anthony Lwegaba. Dr. Anthony is one of those doctors who were there at the time when HIV started, at the time when the medical workers did not know what they were dealing with, at the time when we were scared of the illness. And he's seen us progress from that time to a time where we realize this is just a disease like hypertension or diabetes. Dr. Anthony, it's great to have you here with us. So I'd like to ask you to just share with us a bit of your experiences and also tell us, we aspire to end this epidemic by 2030. Do you think we are on track to do that? What do we need to change if we are not on track? Welcome.
And I observe all the protocols. I feel very honored that 39 years ago, this disease was reported. It has caused a lot of havoc in our society at that time, but the response has been very good. So good that one time I decided, I said, oh, well, I think we've done quite a bit of what we are supposed to do. And I moved on to other areas. After Rakai, I moved to Addis Ababa, then Somaliland, and Singapore, and Southern Sudan, then Karamoja, then after that, the University of West Indies, where I retired a few years back. But I still maintain a home there. My wife and my child still live there. So that's what it is. But I thank you very much for what you have done in regards to HIV/AIDS. And I also feel very happy that this idea of actually stopping it is something that is coming. It's coming at a time when we don't have a vaccine. Because if you know that all the diseases that have been eradicated through a very potent vaccine. But here we are, and we are faced with this disease without a vaccine. So the idea of saying that let us do something about it is very, very important. When I looked at when I was making some notes to come to this workshop, I looked at some of what is happening in other countries. And I thought what we should do is to map HIV groups, specific incidences, and harvest the low-hanging fruit first, where benefits are highest. For example, a few countries, especially small island states, have been satisfied, or are about to eliminate mother-to-child transmission in addition to congenital syphilis. So I believe that we can actually do quite a lot, but maybe do specific programs for those groups where we can achieve greatest. But I also realize that having, from what has been reported, mother-to-child transmission seems to be a little bit tricky here. So we better put in a lot of effort on that. Yes. Okay. Yes.
Okay, thank you. So thank you for that. So I also have the privilege here of inviting Dr. Watiti. Dr. Watiti was my first boss. And Dr. Watiti has, moved from being a patient to being an activist, and he's really conquered this illness. Seeing you coming in, and I was thinking, if we think about people conquering an illness, you are a good example of someone who has conquered that illness, and that is not something easy to achieve. And so I would like to ask you to share with us what are some of the key messages, the key points you'd give someone about living positively, maximizing your potential, and fulfilling what you were created to fulfill, despite the fact that one may get an HIV/AIDS diagnosis. Would like to hear those words of wisdom from you.
Thank you very much. Thank you so much for inviting me and for this opportunity. As you've been told, I think I got infected with HIV around the same time that doctor was working in Rakai. Earlier on, having heard about this disease when I was in the medical school around 83. But now, with hindsight, I think what has helped me, having lived with HIV for over 35 years, actually, because I'm now 70, and I've lived with HIV for over 35 years, with hindsight, is that, one, learning the facts. Never mind I'm a doctor, but the fact that the disease was new, I didn't know. So I think what helped me most is learning the facts. But then, later on, what helped me most I think he's trying to help other people. I remember when I first started practicing HIV medicine at Mildmay in 2004, and there were many children, very sick children, and they were not doing very well on ARVs. And therefore, I was following my medicine at that time. I had improved my adherence, and I was following well. And what challenged me is how to inspire these children to be able to follow their medicine and tell them that they can grow and be like any other child. I remember one child, when he saw me swallowing the medicine, asked me, can I also become a doctor? Of course, at that time it was difficult. But I told him, yeah, I believe if you can swallow your medicine well, of course you don't just become a doctor by swallowing medicine, but if you swallow your medicine, then you can do any other thing, any other person. At that time, I must confess, it was more of, because I didn't know myself, I would live up to 60. At that time, I was still struggling, but then helping other people seems to have been, how helped me more is that when I tell people to adhere to their medicine, it's like I'm talking to myself every day, or helping people to plan to live for a long time. And the young people, of course, who are especially infected with HIV, want to see there is a future. That's when, for example, when we were at Mildmay, I decided to remarry. At that time, it was difficult. But I think I thank God I did that, because now 18 years down the road, and I've not been sick at all. I've not been suffering from any serious illness. Actually, at the moment, more the one which disturbing me most is actually high blood pressure. I developed high blood pressure along the way, and diabetes. So I'm on treatment for diabetes and high blood pressure. At the same time, I swallow ARVs. But I always tell them, my especially young colleagues, that it looks like I'm going to live up to 90 and plus, because so what is it? What is it? Of course, still a big problem, but if we know the facts about the disease, what causes it, how it's transmitted, what can be done, I believe we can live all our lives like I believe I'm lived, because I've lived longer than most Ugandans are going to live currently, in spite of having suffered from some of the most heinous diseases like cryptococcal meningitis and TB and cancer. And by God's grace, I'm here. So my take, especially telling young people living with HIV and all people living with HIV, that the best way to overcome stigma especially is to learn the facts. Because most of the stigma is based on myths, misconceptions, half-truths, conspiracy theories. But if you know the facts as they are, and I can't say I know everything, but I utilize whatever I know as I look for more. So that in a nutshell is to be what it is. Like you mentioned, it's a disease like any other disease. Of course, it's infectious. But now we know that actually, especially for young people, that if you are on treatment and take it the way I take it, that you don't first and foremost die of AIDS, like I've said, but you don't transmit the disease either. So what is the problem if you cannot transmit the disease and you are not going to die of the disease? You can do anything another person can do. So that is what I would say.
Okay.
Thank you.
Okay, thank you so much. Dr. Watiti. Dr. Watiti is the chairperson for NAFOFANU, the network of people living with HIV/AIDS. So
yes, for this week, because next week we are going to have an election, so I'll be the former current chairperson.
Okay, enjoy it while it lasts. So thank you for that. You know, let's continue living positively. Let's also play our role in terms of encouraging people we may know who may be struggling. Women are usually marginalized, so allow me to benefit from being here and allowing Shakira to just give her 2-3 key points that she wanted to emphasize about the role of young people in ending HIV/AIDS.
Yes, thank you so much. Young people's role mainly is to lead and to voice, but also to hold ourselves accountable and other key stakeholders accountable. Key points that I really wanted to leave here mentioning is I want us to reimagine. I want us to begin to reimagine language that we use and think outside of the box and think language that best suits young people in all of their diversity. we always talk about intimate partner violence. And I want to ask all of us that are here, what is so intimate about violence? We need to stop using certain words. In that way, we can better communicate with young people. Violence, we've seen here that the numbers are really, really high. And they're high mainly towards adolescent girls and young and women in general. So we need to communicate these services, health services, to young people as self-care. We all know young people love to take care of themselves in terms of, let's say they have a skincare routine, and they adhere to such things. So we need to start talking about health with young people as if it is self-care to them, and that way we will get better results. Sexual harassment at the workplace. Imi is seated over there. Recently we had a meeting about harassment at the workplace. And civil society organizations, and it's sad that I'm mentioning this, but organizations that we look at, there is sexual harassment happening towards young women in these offices, in these organizations. So we need to check ourselves as we are seated here as gatekeepers of our communities. What are we doing in our offices to really talk about these issues that are affecting women and girls? What policies do we have in place at office? Are they functioning? So I'm challenging all of us to really check ourselves and make sure that we are doing what we are preaching. We are really preaching, or we are doing what we are preaching to the community. Unplanned teenage pregnancies. The numbers are really, really scary. We need to begin to become uncomfortable with these statistics. And that way we will be able to think through and do better, you know? I know oftentimes when we're talking about sex and young people and teenagers, it is a conversation that people do not want to have. But the reality is young people are having sex. And I want us to ask ourselves, all of us that are seated here in this room today, ask yourself, when was the first time you had your sexual encounter? What happened? Did you plan for it? Did you go back and tell your parents if you are below 18 years old? Did you talk to an adult? If you have those answers within yourself, then think about the adolescent girl and young women. We need to equip them with information. Our role as young people, but also as stakeholders, we need to equip our communities with the right information such that they make the right decisions. We have the Choice Manifesto, and this Choice Manifesto talks about, it's a document that was designed by women, by young girls, to really give stakeholders, government, policymakers, the tools on how we want to receive HIV prevention services. And it was recently launched in Uganda by Winnie Byanyima. So this is a document that, this is us crying and saying, this is what we want. We want different services. We talk about choice and getting services to people, but we have had the injection for treatment. Where is it and why are we not accessing it in Uganda? What is the problem and how can we handle that problem? So we need to get, as much as we want to bring the numbers down, we need to make sure people have the tools and can easily access them. Thank you.
Okay, thank you. Thank you so much. I'm sure you still want to listen to these panelists, but this symposium has been organized with more of this kind of information. So we want to just encourage you to stay around and continue learning, and I want to thank all our panelists so much. We would have wanted to listen to much more from you, but we need to end here. And so I'll hand over back to the chair.
Thank you, co-chair. I think to be fair to the general audience, my co-chair had asked you that the theme for this symposium is my responsibility towards ending AIDS by 2030. And she had asked you, what is your role? What have you done? And I think to be fair, we can allow like 5 minutes from interaction. You tell us what your responsibility is. I'd like to introduce and welcome Dr. Noreen Kareba. Dr. Noreen Kareba started TASO many years ago. That's what she did to end AIDS by 2030. I will ask Dr. Anthony Dwega, I think she has some other thing to say. I also say what my responsibility was. I started the first pediatric HIV clinic in Mulago Hospital in 1989. Remember, in 1989, there was no ARVs. We didn't even know what to do with those kids. The only medicine we had was Septrin or cotrimoxazole to treat literally everything. I went to Noreen Kareba Tasso to get the counselors to talk to the mothers of those children, because we didn't even know how to talk to the mothers of those children. So thank you, Noreen, for starting Tasso. Anthony, do you want to say one more word?
Yes, I think we have to encourage people to test. This is very important. I knew I had worked with AIDS for a long time, but I never tested it. I knew that my employees do this each time they sign me for a new job, but they never told me. Then recently, I got a diarrhea, and it was very severe. So the children said, no, we must take you to the hospital. So the moment I arrived at the hospital, I said, why don't I test? Maybe it could even be HIV. So I went and had the test for the first time. So what I'm saying, let us encourage people to test. Fortunately, it was negative.
Dr. Anthony Rwegaba was the DMO of Rakai in 1983, 83 to 85, 86. And as you know, this was really the first time we were hearing of AIDS in Uganda, and he was deep inside. And you know the ravaging that HIV/AIDS did in Rakai in those days. Any more question, any comment on what your responsibility is, what you can do? I think we can allow one or two questions, comments from the audience. Yes, Reverend Gideon, a microphone. Yes, please.
Thank you very much. Canon Professor Gideon Baguma, Biamujisha, my name. I'm really very touched by what members have shared, and also the previous slide on where we are. I feel touched from the sharing that we seem not to be able to defeat the stigma, and that we seem also to be struggling to accompany young people, especially giving them and packaging the services from how they want them to be, not from what we think they need to be. I want to make a proposal for the way forward, that since Uganda is 99.5% religious, and each of those people who are struggling with stigma from the society belongs to a faith community. In the next symposium, the first session, like you have heard, should be a session of faith community leaders, sharing their journey of how they have encountered these issues. For example, you see saying that the laws, the punitive laws, are a challenge. So how are people of faith, leaders of faith, negotiating along those issues? But also, how is the partnership between young people, the legislators, the scientific community, working with people of faith to get out of that quagmire? Because the last mile, the science is there from what I was seeing on the slide. The science is enough. I think God has given us a lot of science, and by the way, we could really clap for that progress. That we are not struggling with lack of what to give people, or, the tests are there, the treatment, but the social and structural drivers. And that is where, again, we people of faith really could give a push if we take our responsibility and are held accountable for it. But we need your prayers, because what I realize is that the people who need love most in order to overcome their vulnerabilities are currently receiving it least. So we need support, not blame, because I think the temptations are blame the religious leaders and so. No, we need you to journey with us as we take Shakila's points inside to see how to repackage our policies, our messages, and our commitments. I commit myself that next year, God willing, I should be one of those presenting on how we have contributed, at least to struggle with making sure that less than 10% of the people who are positive feel the stigma, less than 10% of the people who are in key populations feel, harassed, and Uganda being part of those countries that have really dealt with punitive laws. And so we should be there to give that accountability so that we can have the 95s and 95s and 95s. Thank you very much.
Another veteran, Dr. Sam Okware, was the first program manager of AIDS control in the 1980s. Sam, please.
Ladies and gentlemen, hello? Ladies and gentlemen, I am not making a very big contribution. My contributions were made many years ago, but I have one simple confession to make, and that is to welcome Anthony Regava. He was the district medical officer of Rakai. When I was the senior medical officer in the Ministry of Health, he's the one who came to me and said people are dying of sexually transmitted diseases. I went to investigate. He told me, oh, another one has died. When I was there, he said even his child has died. After 1 week, 20 people had died in one village. I took off because I thought my life was also in danger, because we didn't know what was happening. But nonetheless, he said, no, but I have been here for 6 months and I'm still alive. I would like to thank you for that strong heart. And Mama Noreen, you must also be congratulated. They are the first people. And the bishop, not bishop, I was promoting you, and Gideon. Gideon was the first person, a man of the cloth, who came out openly to say, that was my cohort. I'm just lifting them up so that you can know that you can actually live a full life with HIV/AIDS. However, what started as a rumor, we realized it was a disease, and eventually we accepted it was a tragedy. And tragedy indeed it was in my program. When I started off the program, there were 2 cases that were reported by Dr. Regava. We mobilized all the resources, thanks to the government at that time. We were 52 people who started the program. Out of those, only 2 of us can be accounted for, me and Regaba. The other 50 died, I think, within 6 months of entering into the program. So you can actually see that you had opportunities, which has been the experience of your four friends who went through this exercise. So for the young people, you've got all the tools with you. Please try, don't think that we are joking. Don't think that Gideon is joking or Nareva is joking. The disease is real. Now I know it's a chronic disease, but the disease can still mutate and give you a very serious old condition. Thank you very much. But please, I just wanted to introduce you. When you introduced to me 2 cases, we started the program, 2 HIV/AIDS cases. Now we have 1,001.4. Thank you so much. Thank you for coming.
Thank you, Dr. Kwari. There is a lady who has had a hand there. Yeah.
Good morning, all protocol observed. My name is Femina Achuba. I'm just contributing to what I have done in regard to reduction of HIV. In the 1990s, precisely 1990, I was among the first people working on HIV/AIDS prevention program in the workplace. I did that from 1990 to 93. And I had just graduated. When I started it, I think I was 23 years old. We used to go to work, banks, companies, tea estates, sugar estates in Kcca. We did a lot of sensitization on HIV prevention, demonstrating the use of condom. It felt embarrassing, but with time, we got used to it. After that, I went abroad to do masters. Then much later, I got a job with Ministry of Water and Environment. I didn't know that I was going to be appointed to be an HIV focal person, but that happened. And then I started the HIV/AIDS mainstreaming programs in Ministry of Water and Environment, and developed the first HIV mainstreaming strategy for the Ministry of Water and Environment in 2005. And since then, I'm still the focal person of HIV/AIDS in the Ministry of Water and Environment. And we have since reviewed that strategy 3 times, and we have produced several other documents, the mainstreaming guidelines specific for HIV/AIDS in the Ministry of Water, trainers manuals specifically for the Ministry of Water and Environment. Thank you very much. That's what I did.
I'm being told we have to wind up for the next session because there are now parallel sessions. I want to apologize. Maybe we can continue sharing. Let alone we are still here another 2 more days. So please, let me ask the Secretariat to guide us into the next sessions, which are going to be parallel sessions where they are going to be and so on. Yes, MC.
First, ladies and gentlemen, I think it is befitting that we give Dr. Dennis and Dr. Elizabeth a bigger clap. the chair and the co-chair of the session that has just ended. Thank you very much, Dr. Dennis Tindiebwa and Dr. Elizabeth Echirapa. To the panel, I think let's give the panel a befitting, thanks with a good clap. If there is nothing else you have taken from this panel, I know the content was heavy, very educative, but the testimony and uplifting by Dr. Okware was, I think, the icing on the cake. Out of 50 plus people, only 2 of you can be accounted for. Many years later, we thank God, Dr. Okware, I don't know where he has stepped out to, together with Dr. Noreen, Reverend Gideon, Dr. Watiti, Dr. Wegaba, may God continue blessing you all. Ladies and gentlemen, thanks to those who have clapped. And when you clap for a friend, clap well. Ladies and gentlemen, we are going to move to the next item of the program. We are going to have a break. We will call it a health break. And after that health break, we are going to have a number of breakaway sessions. We have 3 tents where we are going to have different discussions. We are going to shortly give you that discussion. Before we go for the health break, allow me invite the group of performers led by Kcca Mahmood to give us some edutainment for 3 minutes before we go for the break, as you allow us to harmonize which breakaway session is going to be in which tent. This Kcca team is from Tasso Mulago. So, Mr. Kcca, kindly come forward with your team. Mr. Kcca Mahmood, where are you? Mr. Kcca? Aha. Let's pay attention to that drama, and then we will be back shortly.
Come back here. What's wrong with you? Fred! I'm not getting inside. Get inside. Why are you forcing me? If you know that you are my wife, whom I paid dowry for, get inside and give me breakfast right now. Fred, if you know that I'm the wife you paid dowry for, not a mere maid, I'm not getting inside unless you listen to me. Why don't you want to listen to me? Listen to you? Listen to you for what? I'm not listening to you. I'm the man in this house. Get inside and give me breakfast right now. Fred, unless you're going to eat using a fork, I'm not getting inside. Hey! Sir, since when did you start giving orders in this house? I eat using a fork? What's wrong with it? Am I stupid? Get inside. Fred. Okay, I'm going to show you that I'm the man in this house. No fork, no breakfast. Leave me, Fred, you're going to hurt me. Hurt you what? Fred, you're pregnant. Don't tell me, you get inside. Fred! Get inside. Don't take me. Sarah, unless you're going to eat using a fork. Get inside. Sarah, get inside. I'm not coming. Get inside. Fred! Stop. Fred, what's wrong with you? Kalisa, can you imagine? No, this is domestic violence. Forget about domestic violence. Come. Remember, your wife is pregnant. Kalisa, I'm the man in this house. I'll tell you what. I don't know what is wrong with women. Can you imagine that she has denied it to me? Denied it to you? Yes. What? Breakfast. Breakfast? Yes. Just in your breakfast. Kalisa, I don't joke with women. Let me tell you what. I even reached an extent of calling the father. Calling her father? Not the her father. Kalisa, I'm stupid. I'm talking about the parish priest. To do what? He's the one who put us together. So let him come and intervene. Maybe he separates us. Let's get inside. I know the father is on the way coming. You come inside and I tell you. Women! Women!
Mwana wange salo nswaziza nnyo. Olimba! Oyinza otokola ekintu ekifaanaganako bwe kityo. Gwe bw'oli onvamu tebaakubulirira. senga awo teyakugamba nti omusajja tamuwa kantu bw'aba ajagala gimuwe oba ajagala ku makya gwe gimuwe oba mutuntu gimuwe ate wana bwagisanga ku kyoto ng'etokota ng'ebabiridde bweti gimuwe n'ekyemisana n'ekyeggulu otyo ng'ogimumma otya gw'ogigula.
Marita, for sure you didn't understand anything. Marita, like you see, I'm pregnant. I went to the hospital for antenatal care. And while at the hospital, we were given information on HIV and AIDS. And we were told to come with a husband so that we are tested for HIV. When I came, I told my husband refused. But they had told me, if we test together, in case we are HIV pregnant, we are HIV positive, there is a chance of preventing the infection to our unborn baby. When I came, I told my husband refused. I went alone to the hospital. Marita this time was tested. Unfortunately, Marita was found HIV positive. But can you imagine, when I came, I told my husband about this. He said he's not going anywhere. That if I'm positive, he's automatically positive. Marita. Naye Marita, lwaki wafula wakabinga toli? Nkunyonyodde nga tobitegera nkugambye we nagenze mu ddwaliro ne batusomesa ku bya HIV ne batugamba tujje n'abaami baffe batukebere. Yaganye n'enzira yonzekka ne bansanga nga
nanyizibwabwe ye okuwerekerako mu ddwaliro naddala ekiseera kino ky'olimu owetaagibwa ddala ogenda n'omwami wo mu ddwaliro.
Marita,
wanjisebo
Wama, is it true? Is it true?
Nze Kalisa, nze mwami Fred ndaba bulungi sina tulu.
Marita, I'm asking, wama kituufu mbugwe wagenda ne bakebera ne basanga nga olina kawuka nga Kalisa takalina? Is it true?
No. Ekyo kyobadde ogamba ekyo kituufu nnyo. Nagenda ne bankebera nenzira ne ngamba Kalisa ne mugamu n'ebyayonooneka. Nze nibwe nti nina akawuka bwe bagambye ne mutwala ne bamukebera nga Kalisa tayina. Ate nno weewunye n'oluba obudde bumbula ndi mu nnimiro Kalisa agenda mu ddwaliro n'annonera eddagala. Oyo tusanyise okulaba Father.
Oh, we thank God for the gift of life.
Father.
Yes, my son Fred.
You are most welcome.
Thank you. Yes. Yes. I can see new faces here.
Yes, Father.
But God is good.
All the time.
And all the time.
God is good, and that is nature.
Wow.
Yes.
Let's clap for God. Yes. You know how you clap? Oh,
Yeah.
Good.
Father,
Yes.
I know you are in a hurry.
Yes.
Actually, let me introduce that one. That is Kalisa, my neighbor. And the other is Marita, her wife. Yes.
Oh, but I don't see them in the church.
Yeah,
When they
normally
pray.
they don't come to church just because they come on Christmas and Easter. Yeah.
Okay. Now, yes, but by the time you called, I was going to anoint the sick. So I have no time. I think you called me. You had an issue.
Father, I thought that maybe you get inside.
Inside? No, my son Fred.
Okay.
I think, why can't we resolve it from here?
It's okay.
Yes.
Sarah, introduce the issue.
I introduced the issue because I'm the one who called him. Am I the one who called the father?
My son, I think this is a married couple issue.
Yeah.
So I would request you to talk to your neighbors kindly. They give us space.
Kalisa and Marita.
Yes, my daughter.
Marita!
Marita, calm down. Kalisa,
Oh,
I'm going to call you back when we are
Mulungi.
done with the father. You just been here. I know you wanted the father to pray for you, but I'll call you later. Eh?
Yes. After we resolve this issue, he shall call you. Oh, sorry.
Father.
Yes.
Now, you know, me and my wife, Sarah, we have a very small issue.
Yes.
Call that one a small issue. Don't call it small. It's not small.
Father, the issue is, yeah? Okay, let me introduce. The issue is, women are changing. I don't know why. Can you imagine, Father, the woman that I paid the dowry for, the one
Yes.
that I married, has started giving me orders.
Orders?
In this house, yes.
Like?
That I should start eating while using a fork.
Oh.
Imagine.
My son Fred, what's wrong? It's using a fork.
Hey, Father.
Don't you know how to use a fork?
No, it's like this, Father.
Yes.
Maybe this time round, I also talked to you in Proverbs.
Yeah.
What I was meaning. Yeah?
Yes.
Sarah has started giving me orders that when we are going to have sex, we should start using condoms. Yes.
Oh my God. My daughter Sarah. Sex, it was created for procreation. Once you use a condom, no child will be expected. And using a condom, it's a crime. It's abomination. You get me? It's a sin. Now, my son Fred, I've just realized that this is an indication that Satan has invaded your home. So we should humble ourselves and pray. Yes. In the name of...
Excuse me, Father, before you pray, first resolve this matter.
What is it,
Father,
my daughter?
infecting someone intentionally with HIV and using a condom, of the two, what is a sin and what is a crime?
Fred, among you, who is HIV positive? You see? I see. This is, I think, it's a big issue. We need to dig it deeper. So we need to get time. You come to my office, we sit down and resolve it. Okay? My daughter. Yes. So let's pray. Hallelujah.
Father, please. Father.
What is it again?
First, resolve this before you pray. Father.
Yes.
You're the one who put us together.
Yes.
Better do us apart. If Fred doesn't allow to use a condom or go for an HIV test, do us apart. It's good it's you who put us together. Do us apart. What if Fred rapes me? What if he rapes me?
My daughter Sarah, a man cannot rape his own wife.
Is it true? Fred, is it true?
Okay.
What were you trying to do? What were you trying to do?
Wait. And the other issue of putting you apart or to separate you, that mandate as we priests, we don't have it. So, what God put together, no man can asunder. So, my daughter, please, cool down, okay? So, Fred, as I told you, that's what we should do. Get time, come to my office.
Father,
yes.
Before you came, there is something that I learned from Kcca.
Yes.
There's something that he told me while we were inside the house. Let me first call Kcca. Kcca!
So, my daughter,
you come first.
Okay?
Yeah.
A man cannot rape his own wife.
Yeah. Almost. Wait. What's wrong with you? Father. Yeah?
Yes.
I and my friend Kcca.
Yes.
Kcca told me a lot of things about HIV.
HIV.
I realized that for sure my wife loves me.
Yes.
It's not very easy to find a woman who can go for an HIV test and comes back and disclose to you. So, Sarah, I want to apologize. And I want to inform you that I have decided that I should go for an HIV test for sure.
That's good. God is good.
All the time.
And all the time. Yes.
kakati omusajja mukabiridde ebbanga lyonna agende yeekebeze kati akkiriza atogamba no tegeeza ati ono Fred tugenda naye bamukebere nti bamunjeko omusayi gw'akawuka mama ekyo kiyitirivu ajja kubeeteredde abafumbo bagenda kutereokkiriza taata.
Now you are true man.
My son Kalisa, you mean he has been not a true man? Who is a true man? How? How?
Omusajja omutuufu yoyo yejjanjaba najjanjaba n'amakaage najjanjaba ne mukyalo we n'abaana be n'abeera nga kiri bulungi.
Okay, that's good. God is good and all the time.
I want to take this opportunity, Father, to ask you.
You're asking me?
Father.
Okay. Can you hurry up because time is not on our side?
Have you ever tested for HIV? Yes.
No fathers marry. Why do you want him to go for an HIV? Do they marry? Agambye father agende yekebeze sirimu.
Bwebuzibu bwemulina fathers yesi muntu. He is a human being. Akawuka kajirira bantu.
Father, we are very sorry. We are very sorry about my friend Kalisa, Father. We are so sorry.
Amasakaramento agange gogandekere otwalako ga kadisa.
Muleke nammwe. Muleke mwefuye bubi. Kakati bwe kabanga akawuka kajirira bantu. Father si muntu omanyi ekyo baba muzaala nako. Oyinza otya okumanya bw'aba yani.
Okay, my people.
Yes, Father.
God is good.
All the time.
And all the time.
God is good, and that is in nature.
Wow. On this issue, I think Kalisa is right. Being a man and a leader, a man should be a role model.
Exactly.
In his home. Now, as a priest, I should also be a role model. In fact, I'm going to talk to my friends, the Muslims, the sheikh,
yes, Father.
the pastors,
yes, Father.
the reverends.
Yes, Father.
We start preaching the gospel of HIV testing.
Wow, 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 wow.
If you want to end AIDS by 2030,
yes,
we should preach the gospel of HIV testing.
Agenda kubuulira enjiri ey'okwekebeza akawuka bamaseeka abasumba agenda kwekebeza ne bareverand bonna
and today
kikolwabo olw'abasumba n'abafaza n'abakola batya bonna bannanga awo ensi egenda kubeeteredde tugenda kubanga tulinnya akawuka ku nfeete naye nandisabyeyo ekintu kimu n'otakoma mu bafaaza abo bamasheeke baani abo ne gavumenti eno wandibadde ogitutuukirako n'obagamba nti mu basajja wano wakyaliwo ekizibu kale waliwo ekibiina bakiyita pomu ekyo kyokka kyekigezaako okuŋŋanyako ku basajja babamanyise ku byakawuka naye abasajja tebajja mu misomo faaza tuyambe n'ekyo.
This is our responsibility. I've decided to go for an HIV test.
That's very great, Father.
Let me be a role model.
Exactly.
And I think this is going to work.
So, Father, you are going today?
Today.
Right now?
Right now. Do you have any facility around here?
Nearby facility around here.
Okay.
I think we can go.
We can go.
Unite against AIDS. Unite, be safe. Get the facts and get to know what AIDS is all about. Unite against AIDS. Unite, be safe. Bear the facts and get to know what AIDS is all about.
All the time. That God is good, that is nature. Wow.
Yeah. Thank you so much.
Thank you very much, Tasso Mulago, for that very educative drama skit. Ladies and gentlemen, may I invite Commissioner, may I invite Aloysius Matovu to come and offer us a short poem on legends living with HIV. Matovu, ladies and gentlemen, he is a renowned performer in this country. We are blessed to have him. Let's give him a hand clap as he comes to the stage. Matovu, you are most welcome. You are the one who will usher all the groups into the breakaway sessions. You're most welcome.
Hey guys, what's up? Yeah, the name is Aloysius Matovu Joy in that order. By discipline, I'm a linguist. That's what I studied and lectured at Makerere University. By profession, I'm a teacher. And by occupation, I'm an entertainer. And today I'm here to entertain. I have lived with the virus for longer than the life of my kids, and for longer than my marriage with my wife, and they are all safe. And when I'm moving around because I have a passion for young people, I tell them that God so wished that my family should not be living with HIV so that I could be there to save others, not worrying about my own. Dr. Watiti is one of my doctors. Yeah, I remember Samuel Kware when we were doing Indiulira, and he took us to Rajtula Ewamzeim 7. But today, I've got a letter to a friend, a very good friend and a brother. Hey, Stanley, what's up, my man? How are you chopping life? I mean the afterlife down there. How are them stylies with whom in spirit you do converge for jam sessions, strutting guitar strings, blowing the saxos, discussing the percussions, hitting the drums, fingering the keyboards, shaking the rattles, amalgamating the vocals, overwhelming Lucifer's choir, collaborating in unison with angels in heaven. Gwegai, are you in touch with my keyboardists, Tony Sengo and Godi Mwambala? How about my soloist, Dede Majoro? Them Charlies, together with bassist Deo Mkungo, kick-started my music career. Yeah, most of them don't know that I did music before I did drama. Under the tutelage of Big Brother Papa Moi, the perfectionist at Afrigo Studios, Chibuli. The likes of Paul Selmaga, Rashid Musoke, Fred Chikozi. Hey, I miss out on Bilem Tevi's solo. We had a deal, me to find a cure for his ailment and him to strut his solo in my songs. We rehearsed at his flat, Kunabugwaba Road, Yao. I failed miserably. I couldn't find it. It wasn't there. To date, it has never been there. Gwefire, do you remember the Kamauth organ you brought to Radio Uganda studios when we were recording Mike Akande's Fina Mpenzi? It was your excuse for arriving late. I recall Frank Ambalile laughing it off. He knew about your escapades. Wolo tewasula ku Namirembe Road guy. but I'm disturbing your sleep for a reason. It's your call. You lit a candle that lit the whole universe. Mine is to keep it burning, protecting it from wayward winds, living by your legacy against all odds, as a brother, as a friend, as a champion, as a hero. Now here we are kickstarting your festive season to celebrate you as we review and audit our books, concretizing your immortality, honoring your legacy, wondering whether we are living up to your expectations. Remember I told you about the Soldiers for Life program we had started with Uganda People's Defense Forces to fight AIDS among officers and men and communities. You know, with army men, it is about the 3 W's, wine, women, and war. Without war, how do they spend their life? Of course, they will not leave the women, and they will not leave the wine. And that's where AIDS comes in. We even launched a very sexy condom, ulinzi, usiende nyama kwa nyama, naye byafiira awo mbu tewali ssente. Olwaki military tebeera na ssente, olutalo bwe lujja oba ezijjawa, byokambiveeko. So I'm taking it upon myself to end AIDS by 2030, because it's my responsibility to end AIDS by 2030. Yeah, it's a tall order, but not insurmountable. If only parents and teachers were to appreciate this mission to save their children and clients, they would happily invest and entrust their young people's lives in me. And of course, the likes of our gallant combatants. Moses Nsubga Supercharger is doing a good job. The king of the mic, MC Katz, is doing wonderfully. These ones are effectively giving their all to the noble and genuine cause. But the lame excuse is that there is no money. After charging exorbitant fees for tuition, you can't find money to save the lives of your children. Uganda olemwa. And in this my mission 2030, I address teenage pregnancies, gender-based violence, climate change, and the mass of them all, stigma. Oh, Muganda wange, yours was short-lived. Mine is more concentrated than sulfuric and hydrochloric acid mixture. Oh. But I disregard it. I'm used to it. After all, it has no hands to touch me. I've got better fish to fry. I'll traverse this land. The young people would be the best medium of communication and can easily spread the gospel to communities. The testimonies we have of aging people is of Ondiwulira when they were still kids in schools. It's the best way to go if we are to realize the 2030 mission. I've taken time without seeing Tesla. I haven't heard from her. Uganda yajegana nayo yamwegana. There is this kana kakawalya kajwani takawalya. She never tires from checking on me. She's a treasurable asset in this war against AIDS among the artists. World AIDS Day is knocking. Time for Alone and Frightened. Christmas is peeping. Time for Tumusinze. It's your short time, brother. Aluta continua.
Thank you, Aloysius. Joy. Let's give him a bigger clap. Thank you. May I now invite my colleague, Winfred, to run us through some recognitions, and then I will come back after her to announce the breakaway session venues. Thank you. Winfred, you're most welcome. Come over. Let's give her a clap.
Thank you so much, our main MC. Ladies and gentlemen, you're most welcome to the National HIV and AIDS Symposium. And as the theme goes, my responsibility towards ending HIV. So on this note, therefore, allow me to thank our development partners who are around. Allow me to recognize Ms. Sarah Naku. She is the UNAIDS Community Mobilization Advisor. We thank you so much, UNAIDS, for supporting the HIV response. We also have USAID and USAID supported partners. We have TASO, we have Baylor, and IDI. Ladies and gentlemen, civil society have played a great role in providing HIV prevention, care, and treatment services. And also we have FHI 360 in the building, and we should also recognize the private sector. We have the Private Sector Foundation, we have NSSF around, and the media. The media plays a very important role in disseminating HIV messages. So we thank the media in the house, and we urge you to continue disseminating messages, and we ask you to work with us to fight HIV stigma. I think Shakira mentioned of stigmatizing language. A lot of headlines have been running with the headings HIV patients. We seek that we revise the language that we use, because that alone stigmatizes people living with HIV. I would love to recognize the Friends of Canon Gideon. Religious leaders continue to play a vital role in creating awareness for HIV prevention. So we thank you so much. Advocacy. We have community that represent community voices. We have people living with HIV networks, and chaired by Dr. Watiti Stephen. We thank the networks of people living with HIV for mobilizing, for providing referral services and counseling services. Mr. Kato mentioned of the peer-led treatment literacy. We thank the National PLHIV Forum, the International Community of Women Living with HIV in Uganda, and WONETHA and HEPS, Uganet without mention, for advocating for the rights of people living with HIV. And as I conclude, HIV research is critical in both HIV prevention and research for an HIV cure. We thank the Uganda Virus Research Institute, the Joint Clinical Research Center, St. Francis, Baylor, Uganda, and the Uganda Catholic and Protestant Medical Bureau. Thank you so much for supporting HIV research in the country. Last but not least, male involvement is important. We've been looking at the statistics in terms of coverage of HIV services among male. I think we should thank the Positive Men's Union for mobilizing men in the community, and also organizations supporting boys. The boy child is always left behind. So we thank those organizations for standing forward for the boys. The armed forces, we have UPDF and Uganda Police. We recognize your efforts towards the HIV fight in this country. I thank you so much, and I'll keep recognizing the partners in the building. And I invite you all, we have our exhibition tents right behind you, and we also have the community village right opposite this tent. We invite you to come join our civil society organizations and community. We have so much to showcase to you. You're most welcome.
Thank you very much, Winnie. Ladies and gentlemen, we are going to have 4 breakaway sessions. Let me list them out. One is on epidemiology and HIV prevention. May I see Dr. Peter Mudiope of Ministry of Health if he's here. The hand is there. Dr. Peter, kindly stand up so that they see you better. That is the gentleman who is going to chair the session on epidemiology and HIV prevention, and he will be assisted by Daniel Biamukama of Uganda AIDS Commission. Daniel, where are you? Daniel Biamukama is right there. Dr. Daniel, doctor, kindly stand up. I know you are a tall man, you take time to stand. Tall men have a very, you know, their center of gravity is hard to get, so they take long to stand or even sit. So those are the gentlemen who are going to chair the breakaway session that will sit here in this tent. The other breakaway session will be on basic science, care and treatment, and it will be in the other tent, the first tent on my right, on your left, if you're facing me. Now that tent will be chaired by Dr. Andrew Kazibwe of TASO. Andrew, are you here? Dr. Andrew Kazibwe. Aha. Right there, kindly look at him. He's going to chair the second session on basic science, care and treatment. And he will be assisted by Dr. Maureen Kwikiriza of Uganda AIDS Commission. Dr. Kwikiriza, kindly stand up. Yes, that tall lady there. That will be the second breakaway session in that first tent. The third breakaway session will be in the second tent after this one, the second, which is after that, and it will be chaired by SSP Asimwe Ross, Senior Superintendent of Police. Asimwe Ross, are you here? Afande Asimwe Ross. Afande Asimwe Ross, is she here? Stephen, kindly confirm whoever is going to chair a session because we need their members to see them. She will be assisted by Lillian Tabwebwa. Lillian Tabwebwa. Lillian Tabwebwa, are you here? Lillian, kindly stand up so that they can see you better. Lillian is there. She's going to assist Superintendent of Police Asimwe Ross. So if Ross is not there, Lillian, don't hesitate to start. There is a tent behind this one where you will sit. The final breakaway group will be on system strengthening, financing, M&E, supply chain, and human resource. This is a very big session because the issues they're going to be looking at are very wide. And it will be chaired by, of course, given the task, a professor, Professor Damali. Professor Damali, are you here? Professor Damali. Professor is not here. Could she be at the exhibition stalls? Organizers, please, I need us to confirm that these session chairs are available. Damali Nakajnjako is from Makerere University College of Health Sciences, but she will be assisted by Dr. Vincent Bagambe of USC. Dr. Vincent, Director Vincent, will co-chair with Professor Damali. So Dr. Vincent, if the professor is not there, kindly fit in the shoes of a professor and start. We are going to ensure we come and inform you of the time that is allocated to you. It's not infinite timing. You have certain, we have time within which I think it is 30 minutes each. 30 minutes each by the allocation on the schedule, the timetable. So let's take a break right now, and then, and in that time of the break, we can visit the exhibition stalls, and then from there, head straight to our breakaway sessions. The ones who are here, you come back here after visiting the stalls, but let's do the visit in, I think let's do 20 minutes, if possible. We are just trying to recover the time that we have lost. Okay? Is that okay? Yes or yes? Oh, I did. Did I not mention the venues? Did I? I did not. I did. Aha. So, the first group on epidemiology and HIV prevention, chaired by Dr. Peter Mudiope, will sit here. That will be the first group. The second group on basic science, care and treatment, chaired by Dr. Andrew Kazibwe, in the tent there, the first tent. Call it the first small tent. The third group on social support, human rights and gender, chaired by Senior Superintendent of Police Asimwe Ross and Lillian Tabweba, will be in the second tent, the second small tent. There are 3 small tents here. So the next one. And then the final group on systems strengthening, financing, M&E, supply chain, and human resources will be in the third small tent, and it is also along this line. It's only the timing that we have agreed should be 30 minutes. And when you look at, there is this booklet. There is this booklet in front of you. It has been distributed at least to all tables I can see. That book has all the lineups so that you know where you are supposed to go. In case of any clarifications or questions, there is a team that led, I think Stephen is coordinating us, Stephen Asimwe. The gentleman there, kindly look at him, and if you have any questions or clarifications to seek, let him give us the clarity so that we are all clear on what we are supposed to discuss. There are many issues under each of the groups. I don't want to go deeper into them, okay? Just look at this booklet in front of you. Thank you very much. Any other question before we go? We will come and interrupt you accordingly in the different groups if there is need to do that. Okay? Aha, I know the instructions. You remember those things of do not open this booklet until you are told to do so. It was the hardest, even harder than the exam questions themselves to pass. Many people, before they even do anything, they would start by doing exactly what has been prohibited. But I'm sure that this group is going to follow the instructions. Thank you and wish you good luck in the discussions.
So I take over one right now. We are key.
You're not going to visit the stores?
Ladies and gentlemen, if you need to have a bite or a cup of tea, we have some food service vendors right behind you at the different tents. So feel free. It's at a minimal cost. Thank you.
Thank you so much. My name is Peter Mudiope, and I assume all of you are in session 1 because we are starting right away. We do not have time, and Our title is Prevention Interventions for Key. The key to HIV funding, the key to programming. So we are a key population. So members, you can come to the near front row here and we start.
Important message to people who are online. They are participants online. The hashtag that you need to follow is hashtag ending AIDS by 2030. Hashtag ending AIDS by 2030 in order to follow the discussions. Now, there is another important group also online who are on Zoom. They are logged in by Zoom. Now, you can choose using the Zoom link provided that you are following the discussion on the symposium from. Just choose the group you want to join through your Zoom connection and provision. It is possible. That's what the technical team has said. The groups have been provided through the Zoom link, the same Zoom link, and you will choose accordingly the group you want to join for the discussions. Thank you very much.
Hello, which we shall have the discussion. The first presentation will come from Jameson, Miriam Makerere University Joint AIDS Program. Please, Johnson, welcome. Thank you for that clapping.
Yes, good afternoon, ladies and gentlemen. I want to welcome you to this presentation. Miriam Jameson is my name, and I work with the LPHS-EC, a USAID program, under MJAP, Makerere University Joint AIDS Program, as a program officer, HIV prevention. My topic of implementation is improving HIV case identification among female sex workers using trained peers to dispute HIV self-testing kits, a lesson from Namayengo district, and these are highland hotspots. when you look at our implementation, we really realize that HIV case finding is among the adversely affected services during the outbreak. And HIV self-testing is one of the approaches to maintain services during the disruption. When you look at what we look at, according to UNAIDS, during the 2022, we realized that was how far we had moved, and we thought we needed really to get innovations to see how best we optimize and again improve HIV case findings. And when you look at FSWs, this is one of the subpopulation being targeted. And when you look at WFIA 2021, it was one of the subpopulation that had a high prevalence of 32%. Next. Next. So how is the problem? How was that problem? When you look at Q4 2022, Namango district really was not really doing well. Within that quarter, out of the 25 that was expected to have performed, it had identified only 18% of its total budget. And when you look at Namayengo, most of its land area is covered by water, where fishing activities really are happening, and this area is frequented by the FSWs in the area. So having looked at the discordance between the high prevalence of HIV among the FSWs and the performance, we had to do a root cause analysis to find out why is it that however much we have FSWs there, but the case identification was low. And when we did a root cause analysis, we realized there are a number of issues that came along. Stigma being one of the issues among the female sex workers, but again also the discordance between the time these people are doing their activities, but also the time the health workers are providing HIV services at the facilities. They were not really going there because of the time. And this led us also to do further analysis and we realized, second, another slide please, we realized stigma was one of them, and two, however much Ministry had rolled out self-testing kits, testing in the region, there are a number of gaps that were still within. One, the health workers had not yet mastered how to use self-testing kits. There was stigma, and again, the time discordance. And what did we do, or what did we do after that? We identified a facility, and that is the Lolwe Health Center 3, where we called for a meeting with the staff, and what we did was to identify peers. We identified 2 peers. There were 34 peers, and 2 peers per each hotspot, and these were 17 hotspots within the vicinity. And what we did, we really built the capacity of these peers in using self-testing kits. And second to that, we also trained health workers through orienting them on how to use self-testing kits, but again also the data people on how to use data after collecting the data. And after that, we oriented the KPPs to get into the community to distribute self-testing kits to their fellow peers. And after a reaction on a self-testing kit, they direct the KPs to get to the facility for confirmation of these results. Next, please. What were the results after, really, because this was started in October, and what were the results? When you look at the results, Within October, we had not really given out any self-testing kit, but when you look at the results, they kept on really increasing a number of self-testing kits, mainly using OraQuick. A number kept on increasing, and we realized out of the 620 self-testing kits that were distributed, at least 24 people reacted, or female sex workers reacted on self-testing kits. They were brought to the facility for a confirmatory using the national algorithm, and we're happy to report that 17 out of the 24 who reacted on a self-testing kit within that period of time, 17 of them were new infections, or they were newly identified or reacted on determined and confirmed and were linked into care. Next. That is the slide I was talking through. All through, we are looking at the DOA 1, 620 self-testing kits distributed. And again, the second bar green shows that those who reacted on self-testing kit, and the 17, they are the newly identified HIV positive among the female sex workers. Next. Our conclusion was use of assisted HIV self-testing by trained peers involved really improved the case identification among the high-risk and the vulnerable population in Namayingo, and these are the key and priority population, and these are female sex workers. And one of our recommendation is to scale up the use of trained peers to improve case identification among the stigmatized groups. But also, we need to tailor innovations and interventions to the context and the nature of the community where we are working. For example, having sex workers or these vulnerable groups really lead their service interventions, like how we identify the female sex workers to distribute self-testing kits among themselves in the hotspots. Thank you so much for really listening to me, but want to appreciate Uganda Ministry of Health, and again the partners in this, but also the district local government of Namayingo district. Thank you so much for listening.
Thank you so much, Jameson, for that presentation and enlightening us on the need to differentiate services based on client needs and preferences within the specific populations, key populations, especially the sex workers in this case. Before the discussion, please note down, and I ask also Secretariat to take note of the workshops disease of multiple noises encroaching on very important sessions. I pray that the other conference rooms, the noise should be really contained such that people in other rooms can concentrate. So allow me to, that in mind, allow me to invite the second speaker who will be taking us through HIV self-testing and linkage to HIV care preferences among highly mobile men, residents in rural fishing communities of Buvuma district, by Aisha Namwama from Busitema University. Aisha, you have the platform. Secretariat, please load the presentation and also take note that the screen right in front of me is off. Batteries have gone down. Thank you.
I welcome you all on this eminent workshop. Namama Aisha Twahiri is my name. a final year student, a final year MPH student at Makerere University. Sorry, at Ustema University. This piece of work I'm presenting today was nested in a big study known as peer-led HIV self-testing for men that was implemented by Professor Joseph K.B. Matovu. My study basically focused on highly mobile men because men in the fishing communities tend to traverse different islands and fishing communities looking for high fish stock in the lake. Therefore, they are likely to miss out on the conventional HIV prevention services. That's why I decided to study about their preferences when it comes to HIV self-testing, as well as linkage to care in case of a reactive HIV self-test result. Next, please. So, understanding, like I said, that they are highly mobile and likely to miss out on the conventional HIV services. Therefore, understanding their preferences would align their needs to the available HIV services. This, okay. Where do I, like here? I point where? Here. Okay. Therefore, we assessed the HIV self-testing and linkage to care preferences among highly mobile men in Kasali Bee fishing community. Specifically, on the side of self-testing preferences, we basically focused on the kits distribution as well as use. And the parameters there, we focused on the method of self-testing, pre-test counseling option, day of picking an HIV self-test kit, sex of the distributor, cost, and the rest. Then objective 2, we focused on the linkage to care preferences. We basically focused on the preferences for confirmatory testing as well as HIV care in case of a reactive HIV self-test result. And here, we looked at the price for confirmatory test, who does a confirmatory test, when to do it, as well as where to get the first dose of ARVs. Since in the beginning, I told you that this study was nested in the Pest for Men study for Professor Joseph K.B. Matovu. I used the 9 peer leaders that were identified and trained by Pest for Men project who were tasked to identify for me at least 50 men in each social networker group, where we managed to get 400 men out of 448 screened. This data was collected in March 2023. However, we only included men who are aged 15 years and above. And since the studies on mobility on highly mobile, we also screened about those who had moved out of the fishing community for at least once in the past 6 months. We only excluded those who failed to consent and those who were already in PES for Men study where the current research is nested, because they were still undergoing subsequent follow-ups. Those are my results.
Stock out of these self-testing kits. At first, like when it was rolled out in Namaingo or in the EC, NMS, I remember, we had so many kits that were brought, but were stopped from rolling out. So we had not, because they were just phased, it was a phased manner, and we had so many. So by the time we started implementing and using them, they are almost at the verge of all of them expiring. So that was also a problem. We had rolled it out, but again, replenishing, after we had started, it became a challenge. But two, another challenge is how to use them. You know, deep in the villages, you know, the process of using. Now I will talk mainly about the blood-based, the sugar check, and again the INST. The knowledge, it takes a lot of time. People want to be assisted to use the kit most of the time. So you find there is lax and again little, that somebody may not really take it as a whole to use it themselves. They really need to be guided on how to use it. That is also another challenge. But we are using the peers and again also the volunteers and all health workers to be in a position to let people understand how to use a self-testing kit. Simon, yeah, it was intentional to only use female sex workers in these islands. Why? A lot of time I interfaced with the communities. I realized when you get to this lady who is selling sex or who is a flower to the rest, you'll have gotten even others. That's why we purposely, I thought would really tap through this by using the females other than using any other. Because when a female is handled, you'll also find out me, a man, will also be handled. Because if the female sex workers are empowered, so that they may not really have sex without really testing whoever would want to have sex with them, you will have also empowered the man. You'll say, unless we do A, B, C, D, we cannot really have this. And also having empowered the female sex worker will also say, we are not getting to the facility. The first thing is I have the kit where, I have the kit here. Let us do it first, and we shall see the rest later on. So it was purposed to use the female sex workers in this kind of implementation study. Yeah, I want also to appreciate, somebody was saying MJAP is not really felt in some other areas here and there. That could be true, and it could not be. Yes, we are engaging CSOs in wherever we are implementing. For example, when you go to Namaingo as a district, we are working with Siwau, that is in Isigulu Island. We are also working with however much it is not a known CSO in Lolwe or Dolwe Island, but at least we're having there is a beach management kind of unit that we are really working with. It may be hard, or we may not really have gone far in other areas, but we are trying. But also, I think we are engaging with our partners to see how best we can also have. There are other CSOs that have come on board. We are trying to look through the processes of assessment and see how best we can work with them. In Namayengo still we are working with people living with HIV. We realized it is very important to have them. One, they know where their fellows are. Two, they have gone through it. There would be a new leeway of helping the new ones identified also to live positively.
Thank you, Jameson. You should be winding up.
And lastly, Maria, this is really a concern to also us who are implementing. When you look at that graph, it really kept on really moving and again going low. What brought about that issue was also the supplies. There are situations where you cannot really, as an implementer, you may not really manage. So during those months you've seen the drops. Those are the days we didn't have self-testing kits in stock, though they were being demanded. Thank you so much.
Thank you so much. Aisha, please.
Thank you so much for those wonderful questions. The first question was about how would men pick kids from from the peer leaders, at the same time go to the health facility. First of all, this was not an intervention. It was a research work about choice of men in the fishing community. We didn't look at only fishermen. We looked at all men in the fishing community. As long as one was belonging to a certain social network group, because we just used peer leaders to identify for us men in different social network groups. However, about the question that the relationship between peer leaders and health facility, the role of the peer leaders, where the biggest percentage lied, is to just distribute HIV self-test kits. And this is the starting point. And according to the Minister of Health guidelines, for whoever self-tests HIV positive, that person is supposed to go to the health facility to confirm the results. So it is like a must. Then another question was whether would it be affordable for the government. I remember we had a question about the cost of an HIV self-test kit, where a great majority preferred accessing it when it is between 2,000 to 3,000 Ugandan shillings. Therefore, this may be one of the ways of subsidizing the service to reach these men. If at all it is provided at a cost, at least I'm sure it may be sustainable and affordable. Then about peer leaders, there was a question about peer clusters, something. In the fishing community, we found out that we can only access men because of their business schedules. You can only access men when you go through social network groups, though they are not documented. We had different groups, like border groups. We had fishermongers group. We had Banakutuyambagane group, so many groups. But this was the only way I could access these men, because accessing them one by one could be costly, and I could not afford it. Then another question was about how to engage CBOs at the national level. Yes, involving peer leaders, it is already community-based, because if you use peer leaders to reach out the layman, then that is community involvement. Then another question was about so many players when it comes to HIV self-testing and linkage to care, where we have peer leaders, health facilities, counselors, that which one should be taken now. This thing, it may not be easy to use. It cannot be a one-man service. It has to involve a lot of key players, starting with peer leaders at the bottom, until this person reaches a healthy facility. Because this is where this person who has tested positive can access the art services. Since we cannot give these services to peer leaders, they are not educated, they have a certain level. Therefore, their role is to distribute. Then the government is tasked to look at a way how counseling, face-to-face counseling can be provided. But remember, these people prefer unsupervised. That means that these people valued counseling, but preferred privacy when it comes to testing. So different options can be put across, like maybe a telephone helpline for the health workers, to make sure that they cancel out these people. They go to their home areas and cancel them if it is possible.
Thank you. You wind up.
Then about the stigma, and that the kids are picked on the weekdays, not weekend. This result came as a surprise as to why these people would prefer picking kids during the working days instead of the weekend. That's why I recommended further research about preferences on confirmatory HIV testing, and the role of peer leaders to be clarified vis-a-vis the health workers' role, because they are both necessary.
Thank you.
Thank you very much.
Thank you so much. Yeah, they deserve a bigger hand clap than that. So, quite a number of things to pick out from the session. HIV self-testing, we are still on the learning curve, countering a number of challenges. We would like to go more innovative with learning, but also I'm happy young people are coming up with very, very nice presentations. Maybe 20 years ago I was on that side and also presenting, and this is the way to go. We encourage each and every one of you to seize such opportunities, and you do such very beautiful presentations. Thank you so much, the two presenters. I would now like to call the next presenters, that is Benjamin Betunga, Herbert Kadama, and to come up, I think you can, to come to the podium, and Henry Kalunji, and my co-facilitator, Dr. Daniel Bayamukama, please come to the podium. Welcome, we can clap for you, and you get energized. So you'll have each 10 minutes, 9 minutes to present. 1 minute will be for me for clarification if need be, and my co-chair. We will have the presentations loaded, and I would ask IT to come and orient you on how to use this gadget, such that you oh yes, sorry, Jamil Baligobie, please take the seat. Sorry, I missed that. Okay, so we have the first presenter. That is, we have 4 presentations, sorry. That is factors that influence the use of multiple HIV prevention services among transport workers in a city in southwestern Uganda. I don't know that city, but allow me to welcome Benjamin to give us the details of that presentation. Benjamin.
Yes, good afternoon, ladies and gentlemen. I'm Benjamin Betunga, currently a medical intern in Tororo General Hospital. By the time I did this research, I was still at Bishop Stewart University. You will realize I focused on one of the key populations, the transport workers, of which we know that is one of the areas that has the highest HIV prevalence. By that time, 2 years back, I think, 1 year back, the study which was last done on border people in Mbarara City, they found out the prevalence was 9.9%, which was more higher than the countrywide HIV prevalence. So I decided to conduct the study, of which the topic was factors that influence use of multiple HIV prevention services among transport workers in a city in southwestern Uganda, which is Mbarara City now. The transport workers, I'm talking about border, the truck drivers, and then the taxi drivers. So over the last 3 decades, there has been a progress in controlling the HIV epidemic in Uganda. However, we still see the prevalence increasing in those key populations, mostly the sex workers and then the transport workers. So the use of multiple HIV services has been found to decrease the risk of acquiring HIV when tailored to high-risk individuals. However, the uptake of multiple HIV services and factors associated with this uptake, particularly among transport workers, remains unclear. So So our general objective was to investigate the factors that influence the use of multiple HIV services among transport workers. And our first objective was to determine the extent of utilization of multiple HIV prevention services and identify the factors that were associated with the use of multiple HIV services. And then we wanted to determine the level of awareness of multiple HIV services among the transport workers. Next. So we did a cross-sectional study, and it was carried out in 4 slum areas of Malala City. That was Chizungu, Luti, Chianja, and Kakowa. You realize at the same time those are hotspot areas where we have a number of sex workers, and there are also stages for those people who drive trucks and then taxis. So we had a population size of 424, and we included all the adults who were between 18 to 54. We used a research administered questionnaire, and we got our ESICO approval from us to REC. Our data collection started in November 2021 and then proceeded February 2022. We had in our independent variables, which were the demographic factors. We had knowledge, awareness, perceptions, and stigma. And then our primary outcome was to use of multiple HIV preventive services, whereby here we are asking participants how many HIV services they have used in a period of 12 months. So, and these were our results. So from this study, we found out that the most age group was between 25 to 34. Most were single, and they had attained primary and secondary level of education, and most were border drivers. And we found out most people had used only one HIV preventive services. And the most common used service at the moment we found out it was condom. The sources, we found that most of the participants that we interviewed, they had obtained their services from the government facilities. And we found out that most were not able to pay for the services. So just give an example, people like that failed to get money to buy a condom, they would definitely go for a live sex. So I think that's why we still have, or we recorded a higher HIV prevalence in transport workers. So these were, we identified factors that predicted the use of multiple HIV services, where we did multivariate, and then we went to multivariate. The significant items that we got at multivariate, we ran them into the multivariate poison regression, where we had 3 models. In the first model, we enrolled demographics, and the ones that remained significant, we combined them into our second model, which had knowledge, perception, stigma. So, and then we again ran the third model, and we came up with the predictors that were associated to the use of multiple HIV services. So, and according to this table, you can see that participants who were married were more likely to use 2 or more services compared to participants who are not married. And also on the level of education, you would see, we found out that participants who had obtained primary or secondary level of education, they had used 2 or more of the HIV preventive services, unlike those who are not going to school. Also, being aware, we were asking about the participants how many services they knew or they were aware about. So, a participant who knew more than 1 of the HIV preventive services, when we did our multivariate, it was found out that those participants had used 2 of the HIV preventive services, unlike to a participant who only knew, for example, condom use. So still on knowledge, we found out that the participant who had good knowledge was more, or they had used 2 or more HIV preventive services than a participant who had poor knowledge on the HIV services. Also on stigma, the participants who perceived high risk of getting HIV was found to have used at least more than 2 of the HIV services compared to someone who had low stigma. So at the end of this study, we found out that at least use of at least 2 HIV, or you can say multiple HIV services among transport workers was below the average, which was 45.3%. So we found out that behavioral factors appeared more influential than any other individual level factors for the use of multiple HIV prevention services. So we recommend that more differentiated strategies should be implemented to increase awareness and also modify behaviors of these transport workers if we are to achieve maximum utilization of the HIV prevention services. Thank you for listening.
Thank you. You can take your seat. I think the next presenter will go. We shall ask the questions at once. So the next presenter is...
Thank you very much. Good afternoon. My name is Henry Kalunji. I coordinate VMMC in Mubende region and Rwenzori region under Baila, Uganda. So I want us to discuss VMMC and Shangring device in particular. Well, we're going to look at, okay. Yes, I have a couple of co-authors with me, and our topic is Shangring device as an alternative to conventional surgical method to increase voluntary medical male circumcision uptake for HIV prevention, and the story is for basing on the Rwenzori region. Next slide, please. Well, I think accelerating VMMC uptake for HIV prevention requires onboarding of various scientific evidence-based interventions, and the use of Shangring device is one of the interventions that was brought on board, and with support from CDC and Ministry of Health, Uganda is really rolling it out. I think started around 2-3 years ago, and it's really gaining pace despite a few challenges here and there. So in 2021, Baila Uganda, with support from CDC and MOH, led efforts to roll out VMMC Shangring utilization under the VMMC program in Rwenzori region. So important to notice that by the end of January-March 2021, Shangring device uptake was low. It was suboptimal at 0% against the quarterly target of 619. And in this, I want to describe the rollout efforts in having us achieve this and try to improve performance. Next slide, thank you. So this is a fishbone analysis that followed root cause analysis that the team at the facilities sat down and we categorized this into 4 areas, one being people factor, the other one was material, methods, and environment. So during the sessions, we discovered that low uptake for shangring device under the material component was due to the limited or no shangring supplies, then the no shangring IEC materials that are really critical in health education sessions. Then in the environment, we discovered that there was actually very limited community awareness about this other mode of VMMC implementation. Then under methods, we had no shangring services being offered at outreaches, facilities. Then we also had unclear sort of follow-up plan for clients worked on using the shangring device. Then for the people factors, there was a knowledge gap among the health workers and the VHTs. These are really key in giving out information about these services. And of course, there was no skill in shangring operation. Next slide, please. So under the methodology, we now had to conduct a training. This was done at the 4 sites in the Rwenzori region. And we also included, on top of the trainings, there were ongoing mentorships that were done to bring on board as many health workers and VHTs as possible. Then with support from CDC and USAID, the shangring specific sites through the supply chains were delivered to these sites. And the sites were mentored on projections so that we really minimize stockouts and as well as timely ordering of the supplies. So Baylor Uganda in its part supported the first facilities to work with facility QI teams to document the processes that we are going through and the registers, to update the registers and the data tools, and also conduct monthly data reviews to assess our progress towards utilization of shangring devices. Then for the follow-up, an adverse events reporting system, including a dedicated trained person specifically for shangring, was set up at each of these sites. So that, it was quite of a new method coming on board, so it needed really somebody who timely responds to concerns and, can trigger the follow-up system once an adverse event has occurred. Next slide, please. So what did we observe? This is an interesting graph because we realized that at the start, when we conducted the RCA and focus group discussions with the shangring site teams, we started seeing a progress towards improving shangring uptake. And by the October-December 2021 quarter, we still had to conduct more trainings in order to increase on the human resource for health, local government health workers. We had to improve the shangring supplies coming in. Follow-up systems were really kind of active, and monthly shangring data reviews were being done. So we see a spike in the uptake and an improvement of shangring device, which peaked in the April-June quarter, 2022. Then we realized a drop, and this drop was basically due to the limited supplies. This was a national issue. So we sort of scaled down and started offering shangring to only the static sites, meaning we eliminated the outreaches, which were really bringing us numbers before the July-September quarter. So that, however, did not really go down to date. We still maintain a steady flow of clients above the quarterly targets, averaging at around 700, 600 clients in a given quarter. Next slide, please. Next slide, please. Yeah, thank you. So by age group, you realize that in the highest number recorded in this period is between the 15 to 19-year age group. And we also noted an increase in declining trend versus the increase in age. Apart from the 10 to 14-year age group, where Uganda is participating in a sort of, should I call it a sort of a survey being done in sub-Saharan Africa, where we have a few sites that are piloting shangring uptake in the 10 to 14 age group. From 15 years to 30 plus, you realize that the shangring uptake kept declining in Rwenzori region. That's what this particular slide tells us. Next slide, please. Okay, we can continue. So in conclusion, we need to really build capacity of staff through shangring device skills trainings and mentorships, equipping shangring circumcision champions and VHCs with information, regular availability of supplies. I talked about the routinely forecasting need, then provision of IEC materials and robust shangring customized follow-ups. They need to be really as intense as possible, so that since it's a new method on board, so that clients really can opt for it. Then we also look that we needed the deliberate and intentional investment in shangring device method as an alternative to conventional surgical method, because it really brings in people who initially could have feared the surgical method, because, for example, there are no injections given, we use a cream, and the waiting time is low, and lots of other advantages. Next slide, please. Yeah, so thank you very much. Over to you, Chair.
Thank you. I think the next presenter is Jamil. Jamil from HF Uganda.
Thank you. Good afternoon, everyone. Jamil Balgebe is my name. I work with HF, Uganda Cares, as a prevention program manager. We actually undertook a study that we are here to present, and it is a high risk of HIV transmission among partners of people living with HIV and people in detention, temporary detention centers or places. So, globally, we actually know that key and vulnerable populations and their partners contribute the biggest percentage, actually up to 62% of new infections that are occurring among members of key and vulnerable populations. And in Uganda, about 5.8% of the prevalence and was among key and vulnerable populations. And among key populations, HIV was actually reported. Prevalence was reported to be higher among sex workers, fisher folk, and men who have sex with men. And as we can see, for the sex workers, commercial sex workers, it is up to 35%, fisher folk 23%, and MSM 13%. So that actually tells us that our discussion in the morning of, actually mid-morning, of actually saying the key, actually the key, actually is being reflected here. And approximately 1 in 4 new infections occur among key and vulnerable populations. Next. At HF Uganda Cares, we conducted a retrospective study among key and vulnerable populations that tested under the facilities that we are supporting under our testing program. And we analyzed data for clients who tested between January and December 2022, and those were the clients who tested and were 15 years and above are the ones whose data was analyzed, and we are here to present. And we tried to characterize within the wider key populations what is the specific subgroup that is more at high risk and that is presenting with more prevalences. You know, when you are talking about key and vulnerable, it seems a bit bigger and we may not get the picture. So we tried to scale it down And we looked at the different subgroups within the key and vulnerable populations. Among them, we looked at people who inject drugs, partners of people who are back a bit, partners of those who are HIV positive, and adolescents and young women. So the total tests that we conducted in the year 2022, we tested 310. So we tested 310, 890 clients in the reference period of 1 year. And out of that, 69% were females, and 25% of those who tested were from the key and vulnerable populations. So overall, among the key and vulnerable populations, HIV prevalence was 3.5, and it was high among women and older persons. It was high among older persons. And then, what were our findings? Our findings, when we stratified by key and vulnerable population subgroups, we found 11% prevalence among previously negative sexual partners for people living with HIV. We had testimonies here in the morning where people have lived with positive partners, but they are not seroconverting. But in our study, we found that we are seeing more people actually seroconverting. They were previously negative, but staying with a positive partner, and 11% of them seroconverted, and 6.9 among people in temporary detention centers. Also, prevalence was 6.9. And then, among those who use drugs, prevalence was 3.9, and that was just a breakdown. Let us go to the next slide. Yes. So we tried to make sense of the data, and what you are seeing there in blue, the blue bars, the subgroups within the key and priority populations, and that red curve that we are seeing is actually telling us the positivity among the different subgroups. And as we are seeing, the curve goes down and goes up. It peaks around subpopulation 3, which is prisoners and people in temporary detentions. And also at the extreme end, where we have partners of people living with HIV. These partners were previously negative, but in the subsequent year, they became positive. So we are seeing an increase, as we are seeing in the curve, of going up, meaning we really need to have an intervention there. Within the key populations, we need to focus on partners of people who are living with HIV, who are negative. Risk among the subpopulations, we tried to look at the different risks within the subpopulations of key and vulnerable populations. And the negative partners of sexual partners living with HIV were 2 times more likely to get HIV compared to sexual partners of general key populations. So within the basket of key populations, we compared those who are living with a partner who is positive, and generally the partners of KP. And we found those who are living with HIV, partners living with HIV were 2 times more. Also, those using drugs were relatively more than those who were injecting drugs, and the detainees were also slightly more than those who are compared for mobile populations. Next. So in conclusion, we are saying that we are seeing quite a number of previously negative partners living with people who are positive, seroconverting in a period of time. So we need to, there is an indication that maybe there is less combination prevention that is being utilized. And our recommendations are we need to scale up access to differentiated combination HIV prevention services for key and vulnerable populations. Then we need to targeted scale up of cutting-edge biomedical interventions, such as PrEP, for HIV negative partners of people who are living with people who are living positive. Say partners of people who are living with HIV, should be targeted for PrEP in order to reduce on the infections that are occurring. And then there's need for more inquiry in the validity. You know, we have read about it. It has been published widely, but from what we found out, we need to really have more inquiry on the validity of the concept of undetectable equals untransmissible, given that we are seeing partners who were previously negative actually seroconverting. So is it the issue of perception that when I'm non-detectable, therefore I can't transmit, so there is no other use of any prevention or intervention? So there is need for more research on that, and that is what we found out. Thank you so much.
Thank you. I think there are questions there. That finding was a very important finding because we are challenged with U equals U in our context. Thank you for the study. Dr. Kadama.
By the name's Dr. Herbert Kadama, working with the Ministry of Health and coordinating the PrEP program. I will be taking you through the multi-choice mix for HIV prevention and why we are looking at people having different choices for HIV prevention. Thank you. Maybe you can get the slides. Yes, she sent them to the Secretariat. Yeah. So I will be talking about expanding the PrEP options and access for women. That is creating policies and piloting the PrEP ring and the Kabla PrEP in Uganda. So briefly, I wanted to go through the journey of PrEP in this country. We initiated the oral PrEP in December 2016. That's when we came up with a policy to guide the implementation of PrEP. But actual implementation started in July 2017 with 6 sites. We are scaling up PrEP through a phased funded approach, and the modes of implementation are both facility-based and community-based approaches. So as I talk now, we are in 15 regions out of the 16 health regions of the country, and we cover 65 districts, and we are in 587 health facilities across the country. And over 400,000 clients have ever been initiated on PrEP by the last quarter. So I will be talking about the rationale, progress, and plans for introducing the new PrEP products, that is the ring and the injection PrEP. So we know that the available methods have challenges, and the challenges we are having are mainly low uptake and also low persistence. And this one is a result partly of lack of discrete products that are under the control of the user. And we know very well that there is no single product which can solve and be I mean, which can solve all the users' what needs at the different life cycle, especially of a female. You know, the female has a different reproductive health cycle. It goes through pregnancy, it goes through breastfeeding, and there are moments when she is neither breastfeeding or pregnant. So women particularly need to prevent HIV, as I've said, in the different reproductive phases, using either daily, monthly, or slightly longer choices, and both choices which are either local or systemic in nature. Next slide. So now I'm moving to the different choices we are introducing. I will start by the event-driven PrEP. This is mainly for men, or those assigned male at birth. And that is what we talk about, the 2-1-1, 2 pills, 2 hours to 24 hours before the sexual event, followed by 1 pill, 24 hours after the first 2 pills, and then followed by 1 pill to 48 hours after the last pill. So we, as a country, we have started giving event-driven PrEP. We went to Eswatini, which has a very promising PrEP, ED PrEP implementation. And when we came back, we managed to incorporate ED PrEP into our technical guidelines, and we also developed ED implementation guidelines to guide the implementation of PrEP in the country. So we reviewed and updated our training curricula to include ED PrEP, and now as I talk, we have had a national TOT, training of trainers on ED PrEP, and we are rolling out ED PrEP. Next slide, can go. In 10, what we call pilot facilities, and in these pilot facilities, we are having intensive supervision and mentorships so that they guide us on how we can scale up PrEP after here, after learning issues to do with the acceptability and feasibility of ED PrEP. But as I talk now, since we have weekly meetings, the results are promising. And we are planning to roll out ED PrEP beginning in January into all other regions of the country. Currently, we are using the facility-based mode, but as we continue, we shall also start giving out ED PrEP through the community-based approaches. The other method we are rolling out is the dapivirine vaginal ring, or sometimes we call it the PrEP ring. The PrEP ring, as you can see in that picture, is a flexible silicone vaginal ring, and it contains a drug called dapivirine, which is slowly released in the vaginal mucosa when it is inserted in the vagina. And this is a woman-initiated method. They can do self-insertion or assisted, usually when they are beginning. It is discreet, but most of all, from all the researches which have been done, it does not interfere with the sex. And it is long-acting. It takes 28 days when it is inserted in the vaginal mucosa, and it is stored at room temperature, so we don't have any worries about cold chain. Next slide. So the ring has already been approved by NDA. That was way back in October 2021. And we have also included it already into our technical guidelines and even in our HMIS tools. Currently, we are carrying out demonstration projects in 7 sites under the Catalyst study, which is under USAID Mosaic project, to find out issues to do with the acceptability, feasibility, what are the barriers and enablers of uptake of the ring. And when we complete this, we hope to do a phased rollout nationally, and this rollout will be guided by the PrEP targets we are developing using a tool which is called PrEP-IT. And I want to say that under the Global Fund application, which has ended, we expect to get around the ring for 30,000 individuals by the year 2026. Next slide. So the other one is the carb PrEP, which is also called the injection. And this one is also used in preventing HIV, especially among the high-risk populations. And it is an injection given in the buttock. It is given month 0, followed by month 1, then followed by month 3, or after every 2 months thereafter. And it takes about 1 week to be effective. And here we expect that a person using this injection should be using another method within this 1 week, so long as to get protected against HIV. So when someone stops using the injection, there is some drug which remains the carb in his body for around 1 year. This one is not enough to protect this individual against HIV, but why we call it a tail, but our fear is that somebody, if he gets infected, he can easily get resistance to the carbidopa. And we know that DTG is one of the drugs within that, and we don't want to have that. So if someone is still at risk, this is a period where we expect them to be using another HIV prevention method, which he accepts and is cancelled on. So this one, the injection has not yet been approved by NDA, but once done, we shall have also demonstration projects within the 7 sites under the Mosaic project. Next slide. The other thing we are doing is introducing PrEP in the private pharmacies. So here, we have already developed a concept note, and it has already been discussed with the technical working group. The pharmacies have been assessed, and we are riding on these pharmacies which are already providing ART for those who are HIV positive in the private pharmacies. They are the ones we are riding on. And currently, we are developing guidelines on how this public-private partnership will flow out, provide PrEP within the private pharmacies. As I end, I just want people to know that we have a number of researches going on in the country on PrEP. I had already said we have the implementation study on the PrEP ring and the injection PrEP by Mosaic. We have the 6-month injection, which is being studied under Mujo in a number of facilities, Chivoga being one of them. So we have also a study which is being done by IDI, especially for PrEP in those people who injected drugs. And Makerere University School of Public Health is evaluating the PrEP delivery models, that is facility vis-a-vis the community. And also, there is a study which we are doing, which I think I will be presenting tomorrow, the results on PrEP uptake and continuity, which was a quality improvement collaborative between the Ministry of Health, UHA, and the METS. So, what are the priorities as a country? Beginning next year, we want to roll out the vaginal ring I had alluded to, 30,000 by 2026. We want to use virtual platforms to increase PrEP uptake and continuity. I want to tell people that we have what we call Uganda PrEP app, which can be downloaded by those who have the Android operating system of the phone. It's not yet on the Apple, but it guides people where there is PrEP, common questions, adherence issues. It has a lot of information. It can be downloaded from the Google app. Then we are going to scale up PrEP, both geographically and in the subpopulations, especially the pregnant and breastfeeding, where we are seeing a lot of new infections and the AGYWs. And we hope that we want to move from the 587 facilities to the 1,500 facilities in the 145 districts by the year 2026. We're also looking at strengthening the community and private-public partnerships, and especially, I've said, provision of PrEP in the private sector, and strengthening the PrEP communication strategies and framework in order to increase demand for PrEP. I would like to end by thanking our PEPFAR partners, USAID, CDC, and DOD, the Mosaic Project, Global Fund, UN partners, South-to-South Learning Network, then implementing partners, DHTs, health facilities, and health workers. And lastly, but not least, CSOs, CBOs, peers, and the end users. Thank you.
So thank you, our panelists. Good afternoon, colleagues. We are sorry for keeping you hungry, but we thank you for your indulgence. And we welcome our partners who joined us while we were already in the session, including partners from the UN family. I've seen paper partners and all implementing partners. So it's time for questions. I know you're hungry, but we have just received 4 presentations, 2 which were basically about program rollout. One about PrEP by Dr. Kadama, and the other about the rollout of a shangring, a circumcision strategy approach by Henry Karungi from Beira, and 2 presentations about populations, transport workers in Imbarara by the gentleman from Bishop Stewart University. I want to congratulate you among the young people who have made clear presentations today. So he studied transport workers, border, taxi drivers, and truck drivers in Imbarara, and what influences the uptake of multiple prevention services. And discovered that most of the services they took up were mainly condoms, but he articulated the other factors that determine those who take up more than a condom or more than the services. And the other presentation, of course, was about seroconversion, which introduced something that is good for a discussion, which has an implication, because right now, we are considering as a country, we are reviewing our national policy, and the key on our agenda is to adopt the U=U strategy. But you notice that in his submission, he appears to conclude that we need to think again before we adopt the U=U strategy for our setting, because he studied seroconversion, the rate seroconversion among partners of key populations and people living with HIV. And he documented significant conversion rates that caused him to conclude that we need to rethink U equals U as a main conclusion. But of course, he made several recommendations, and I want at this juncture to invite the audience. I see the MC already pointing at me that he has given me 10 minutes. So let's have your questions answered. So by show of hands, who has the microphone? Please, move the mic. Let's see, are we letting the panelists tell us how they interpreted their results? So by show of hands, I will accept the first 4 questions, and I will not go beyond 4 questions because of time. The question I wanted, okay, thank you. Those 2? One more question? Okay, thank you.
Thank you so much. I'm Emi Mulumba from Moju. We know PrEP is effective. Since you want to continue preventing HIV, I want to ask the previous speaker, what strategies do you have to rule out rumors from the communities? Because we know people don't know much about PrEP, and since also Kabla is new, we want to find ways of stopping rumors, because it's not easy to start something when you're not aware about it.
Thank you very much. Next question.
Thank you so much. Ms. Kababilio team from Muju. My question goes to the previous speaker. We just had a study called Insight that was looking at adolescents and young women and giving them PrEP. After the end of the study, most of them, okay, we tried to link them to care, but most of the girls either didn't go or went and stopped along the way. What's your comment on that? Thank you.
Okay, thank you very much. Jennifer is my name. Okay, one, I would like to comment on the gentleman who spoke about the U equals U thing, that concept. Clearly, we can see that our government, or even MOH, actually is rethinking about inputting it or implementing it, or even adding it as a concept for prevention. However, concerning your data, I feel like it's kind of a little bit not sufficient enough to overthrow the concept of U equals U. That is my first comment. Because now we are not really sure whether these people who seroconverted, the issue was actually because they did not involve with other kind of people who maybe had a high viremia, something like that. So to me, I think that before we even rethink about it, there is need for more research and your study. That is one. Number 2, it goes to the gentleman of PrEP. Yeah? So here we are thinking of bringing up or coming up with the cabotegravir long-acting cabotegravir as a PrEP. Yeah? However, have we really researched about it that even when because currently we are seeing people failing on the DTG-based regimen. So when we use it, we go ahead and use it on people who are engaging with people that are failing on the DTG. Will it still work? That is my other question. Thank you.
So, okay, I think you asked a very good question. If I had the authority, I would ask the people to clap for you. The question is, the conclusion that U equals U may not be okay. Did you prove that actually the new infections, the seroconversion was because of their partners? That would be key before we say we cannot. So I think she asked a very good question, and the additional question, and the question from Mulumba and Babirie to Dr. Kadama. The first one is strategies. You have to stop the rumors, the misconceptions, failed linkages, and the other questions from Jennifer, I think are directed to you. So you can have the floor. You don't even have to come here in less than 3 minutes.
Thank you, Chair, and thank you, our listeners who have asked questions. Actually, if you see my conclusion, I actually also highlighted it, that we need to do more research on it because it is a known fact, it has been a known fact that once you are positive and you're on treatment, chances of transmitting are actually what? Low. And therefore, we expect your partner who is negative to actually remain being negative over time. But you, again, studies actually, our findings are showing us otherwise, that again, we are seeing more partners of people who are on treatment seroconverting. There is need for more studies. So this is not a conclusive study, but it is just a pointer that we need maybe to look in that direction. Are we not doing something right somewhere? Are our negative partners not doing right? Or our positive partners not doing right? So it is something that we need to dig deep and find out. But that is what we found out, and we had to share, because it was also, you know, to us, we looked at it as unique in its own way, given that we know from all the publications that U equals U. But if, again, more partners are getting infected, who were previously negative and staying with positive partners who are on treatment, it brings questions. So, Chair, I actually don't want to say I'm concluding on that, but it is something we need to take up.
Yes, thank you. I will start by, you talked about the myth and misconceptions. Well, as a ministry, we have the PrEP communication strategy and framework. So this one guides on how to communicate about PrEP, through communication about PrEP, and it is current, as you expressed, undergoing review and revision to include the injectable PrEP and issues to do with the ED PrEP and the PrEP ring. So it's from that that we shall develop materials and messages that will go out to the community to dispel those myths and misconceptions. And also riding on the community strategy, which addresses client literacy. We shall use also, that's one of the strategies. Then the other thing, you will say you are doing a study and you are linking the AGYW, but they are not reaching. But that one, I think you do us a favor and find out why they are not reaching. Because for now, I think the strategy will be to find out why the AGYW are not reaching the facilities. What are their concerns? Lastly, your expression about the carpetographer, I think this one has been researched and recommended by WHO for use as a prevention, and if it is used correctly, we shall not get issues to do with the resistance, and that's why we are running, first of all, the demonstration projects under the Mosaic project, which will guide us on how to fully implement Kabla or injectable PrEP into the country. Thank you.
So thank you, panelists. You can clap for our panelists, please. I want to hand over to the substantive chair of the session to summarize the session for us, and in 5 minutes we should quit.
Thank you, colleagues, for persevering in this hot afternoon and staying till the end of the session. We have had very good presentations, papers, and also programmatic issues discussed this afternoon. Thank you so much to the presenters, and thank you so much to the audience, those who ask questions. This is accountability. This is pausing to see where we want to go as a country. So specifically for this session, and please, there is a follow-on session tomorrow on HIV prevention among the key. We said key, the key, door key. If you don't open the room, the door where those key people are, there is no end to HIV/AIDS. So please get interested in attending these sessions where we discuss the key key issues, keys to the door, to the room that enters, where issues of HIV, ending HIV by 2030 are discussed. So in those 6 papers, things that came out, the highlights, maybe I start from the last one, where it was about PrEP programming from Harvard, discuss how the ministry is positioning and the country is positioning to roll out PrEP. And clearly it was noted that not only PrEP, but all the interventions for prevention are suboptimally rolled out in the country. Can imagine for PrEP, we are not yet there. We are only in something like 600 sites of the 1,500 sites that we want to go to. We have not yet reached the 145 districts. So what happens to the rest of the districts at the moment? Are they in Uganda under your program, sir? They are not yet under the program of Harvard on PrEP programming. So, and that is only for PrEP, but all interventions are still suboptimal. That's something to take home about. We have, and that is for oral PrEP, but the new interventions like ED PrEP, DVR, and Cabel-A, to some extent, even these so well-proven interventions globally are not yet approved by NDA. We also had a paper in the morning presented by somebody from, I think, Namayingo, where HIV self-testing went down and people asked questions, how come? Clearly it was explained that there is a shortage of HIV self-testing kits in the country. This is well known. I know discussions are going around, but we need to really look into it more as a country. Research is really still important to find the best models, to find the best interventions to end HIV/AIDS. Issues that are holding us behind: knowledge, stigma, social behavioral factors came out prominently in the presentation. Not only that, among the communities, but even the health workers. For example, we heard they didn't know how to use HIV self-testing kits, and this attracts a lot of capacity building among the health workers. We are not yet there, and this is only in the 45 districts we have reached. What about the 145 districts? There's a lot to do. Scope and geography is limited. I've mentioned that, and continuous research needed. Ladies and gentlemen, quite a number of things were mentioned, but I want to come to the end, the close of this session, and I say I thank you, I thank you, I thank you so much. Please clap for the presenters and my co-chair, Daniel Biamkama. I am Peter Mdiope from the Ministry of Health. Thank you. Maybe an announcement is that we are supposed to go for a brief lunch session, and we'll be connecting with the main session, which will be here in this room starting shortly. It will entail the opening ceremony where we shall have the dignitaries recognized, and also we shall have the ministers, government officers, and colleagues from civil society and the donors. So we are requesting you, if you're going for a break, to really do it very fast and come back to take your seats, and we start the session. Is it on time or in time? Slightly on time. Thank you.
and services involved in the fight against HIV/AIDS. I want to also recognize the presence of Dr. Eddie, the Uganda AIDS Commission board chair, the executive director, Dr. Vincent the representative of the executive director. Dr. Vincent, kindly stand up for recognition. And many of you who have found it important to be here. Winnie, please come forward and Winnie is going to recognize for us the different persons who are exhibiting. It's important that we take note of the different products that are being exhibited, because much as this is a symposium, it's also important in the sense that we have exhibitions by the various partners who are involved in the fight against HIV/AIDS in Uganda. Winnie, you're most welcome.
Thank you so much. Before I recognize the partners in the HIV response, allow me in a special way recognize the presence of Honorable Ayebare Margaret Rebiambu. She is the woman MP in Barra District. You're most welcome. And she'll be chairing the afternoon session. Ladies and gentlemen, once more, allow me to recognize partners and civil society organizations that have been supporting the HIV response, and they've also been able to showcase some of their work. I think you've been touring the different exhibition stalls and tents. So we have TASO. TASO is a center of excellence in HIV care and treatment. In fact, TASO was the first organization to come up with interventions supporting community psychosocial support programs, and then scaled up to treatment, and here we are. So we want to thank TASO so much for supporting the HIV response. We also have Uganda Cares. Uganda Cares provides care and treatment programs, both in the central region and across the country. We thank Uganda Cares so much. We also have Muju. Muju is Makerere University. Muju is Makerere University Joint Health Program. Muju undertakes research in the country. And then we have Makerere University Walter Reed Program, also supporting with HIV prevention, care and treatment research. And of recent, they are going to start the HIV cure research program called HOPE. So we hope that we shall have an HIV cure someday. We have Baylor Uganda and we have Baylor Uganda and Makerere University School of Public Health program. It is not only an academic institution, but also undertakes research. So we recognize Makerere University School of Public Health. And we have ANECA. ANECA supports pediatric HIV prevention and care treatment programs, and we are honored to have Dr. Tindieva. He was chairing the morning session. We are so honored to have you again. And then we have AMICAL. AMICAL is an alliance of leaders in the HIV response. And then we do have the Uganda Catholic Medical Bureau and Protestant Bureau. And aside of HIV prevention, we have civil society organizations that support advocacy programs in the country and community networks of people living with HIV, both at national and district level. I saw Kitgum district here. I was also able to see a rural network of people living with HIV. And we had Dr. Wachiti Stephen, who chairs the National PLHIV Forum at national level. And we have a board member from Nafofanu here, Ms. Jane Mirimuvi. You're most welcome. I also want to recognize the Armed Forces, UPDF, right behind there. We thank you so much for honoring our invitation. And then we also have IDI. The IDI team is showcasing right behind you. And we have St. Francis Hospital, and then the private sector. We have NSSF on board. We have the media fraternity, and also the self-coordinating entity. And then we do also have students, the Uganda National Students Association, because we believe in working with young people. We have UNASO also on board, among others, quite a lot of partners. We have also the fellowship on TB partnership and the Stop TB partnership, among others. Thank you so much. And lastly, I would also love to inform you that we have a community village just opposite this tent. We do not only believe in biomedical interventions, we believe in the combination prevention approach, structure. So anything to do with structural interventions has been happening right in the other tent. And it is done in such a special way that we are using drama, we are using poetry, singing and dancing to create awareness on HIV prevention. So feel free to also join the other tent. Thank you so much. I would love to welcome my MC, the main MC. Oh, right behind me.
Before I invite the chair of this afternoon's session, we are going to have a drama skit as part of the edutainment by the Legends. Is the Legends group here? The Legends that are supposed to perform this afternoon? The Legends, are they here? If the Legends are not here yet, I think if the Legends are not here yet, allow me now to take this opportunity to invite Honorable Ayebare Margaret Rwebyambo, MP from Mbarara District, who is going to chair this afternoon session. As I was briefing her, I told her that there could never have been any better chair this afternoon. The last 2 weeks, one of the highlights of the discussions on HIV/AIDS says that Mbarara District is now the new focus because the trends, prevalence trends, are showing that it is now leading, and especially the young people. So, Honorable, you are an MP of Mbarara. We need you to tell us your own responsibility towards ending AIDS by 2030, especially in light of the new report of the research, and now you have a bigger role than you had anticipated when you were coming for the 2021 elections. I want to welcome you, and you take over the microphone. You're most welcome, Honorable.
Thank you so much, our moderator of the day. I don't know whether I should speak from here or as they have already told you, my name's Ayebare Margaret Rwebyambo, and I represent the people of Mbarara District in the 11th Parliament of Uganda. And most importantly, I sit on the HIV and AIDS Committee of Parliament, and I'm glad to be here and to take up the chair in this afternoon. I want to take this opportunity to thank every one of you who are here to participate in this HIV and AIDS Symposium. I don't know whether it would be right for what he has said that I'm chanced to be here after Mbarara has been spot on having the highest HIV prevalence of the rural area in this country. As I've told you that I sit on HIV/AIDS Committee of Parliament, when I reached Parliament, I chose to sit on that committee as a standing committee, and I also sit on Health Committee as a sectoral committee because of the background that I had before I joined politics. I worked with the Ministry of Health, specifically Mulago Hospital at the National STI Control Unit, with key populations programs. And I saw a lot to do with HIV programs. And when I joined Parliament, I had that background and that, interest in sitting on these committees to ensure that one or two things can be done for the people living with HIV, and also forge ways and strategies of how we can end HIV in this country. So today I feel so honored to be here and to chair a session in this afternoon program. Mbarara, as they have said, when I hear that it has the highest HIV prevalence, it brings me back to what responsibility do I have in ending HIV in this country. And as I've already said, that sitting on the HIV committee was a reason to see how I can end HIV in this country, or how I can contribute to ending HIV in this country. I want to bring this to your attention that I represent Mbarara district. There is Mbarara district and Mbarara city. Mbarara city's HIV prevalence is 8.1, and Mbarara district is 14.4. So you can imagine when a rural area's prevalence becomes higher than the city prevalence, it becomes worrying, especially to me as a leader who is a member of Parliament, and especially when it is like the more HIV is in young women, of which women are the ones that I represent. So I want to request all of you to give me support. I don't know what Uganda AIDS Commission has as the next strategy. When I see doctors here that I used to work with when I was still there, I know you're not going to leave me alone. We have to forge ways and means and strategies on how to end HIV, beginning with Mbarara. Kindly, the developing partners that are here, I think you need to work with me and see how best we can end HIV, beginning with Mbarara, though it is targeting the whole country. We are still waiting for the guest of honor, as we are all aware, but we all know that time is not going to wait for all of us. So I want to take this opportunity to invite the keynote speaker of this afternoon, who is going to tell us about ending the HIV vulnerability dilemma among adolescent girls and young women, and what we need to do better, maybe than what we've been doing. And this is other than UNFPA country representative, Daniel Alem. Let's join hands to welcome I've been informed that the next presenter who is going to give us keynote speech is not yet in the tent, but will be here in the next like two minutes. So I think we can wait for the 2 minutes as he comes in to give us the keynote address on what do we need to do better than what we've been doing to end HIV, especially in the vulnerable groups in this country. And as we wait for that one, I want to take this opportunity to welcome the U.S. Ambassador to Uganda, His Excellency William Dopp. You're welcome, Your Excellency, to this meeting, and we are glad to have you here this afternoon. So as we continue to wait for the next speaker, I want to say that one of the events of this symposium is looking at those people who were here before us that moved the journey of HIV and AIDS. And what do we learn from them? We all know that we are commemorating one of the great men in this country by the names of Philip Bongere Rutaya, who came out to speak about HIV and AIDS. Despite the stigma that comes with HIV and AIDS, despite the discrimination that comes with it, this gentleman, may his soul rest in eternal peace, came out boldly and said that he was infected with HIV. So today, as we stand to remember him, what do we learn from him? What do we learn from the exposure? What do we learn from disclosing that you have HIV? As we look for different ways to end HIV in this country, what do you and me learn from Philip Bongere Rutaya? As young people, because I remember when you're reading what he left behind, he had messages for young people, and I'm being informed that there are young people in this tent from different universities. My question to you, or my message to you, is what do we learn from Philip Bongere Rutaya's message? Do we still abstain as he really told us before he went to live another life? His two messages were abstinence, if you can. His message was if you have not contracted HIV, how do you continue to live without it? And his second message was, how do you take your drugs religiously that even when you have the virus with you, you can still live and maybe achieve what you thought you would achieve in this world? So as we go on, I want us as young people to reflect on this Fide Lutaya's piece of advice. I think we can move on to the next presenter as we wait for the UNFPA country representative who is supposed to give us the keynote address. And at this time, I'm going to invite Mr. Raymond Kcca, who is going to give us a statement representing the people living with HIV and AIDS. Raymond, is he in the house? Oh, you're welcome. Another hand of applause as we welcome Raymond to give us a statement representing the people living with HIV and AIDS. I thank you.
Thank you very much, moderator. Our distinguished guests, protocol observed. Greetings from Nafafando and the PLHIV constituency. This is a statement by the people living with HIV presented on this day. As a constituency of people living with HIV, we are delighted to be part of the National HIV and AIDS Symposium, where we have gathered to take stock of what we have achieved during this year and explore opportunities ahead as we move the last mile towards epidemic control by 2030. We are very grateful to the government of Uganda for the support rendered, our donors and the development partners, to over 1.4 million people living with HIV, that our lives have been impacted positively and our quality of life has greatly improved. This year's symposium theme of my responsibility towards ending AIDS by 2030 reminds us of a joint commitment and collective efforts towards a common enemy. It is at this point that we reflect on the milestones in achieving the 95-95 targets, which guide us in reaching the epidemic control. We have done well in the second 95, where access to life-saving antiretrovirals has been possible. However, efforts are still needed for the first and third 95 to reduce the spread of the infection and cost in treatment of advanced HIV disease. There are other gaps, such as disclosure at workplaces. Treatment literacy levels still remain very low. Intermittent stockout of drugs and commodities for HIV and TB. The fear that the donors may pull out of funding HIV treatment, leading to many of us to die as domestic funding has remained low, and the AIDS Trust Fund operationalized since 2014. Besides, stigma remains a structural barrier. Prevention efforts, socio-economic programs do not target people living with HIV as a special category, and our children, adolescents, and young people require special programs as viral load suppression has remained low among these age categories. It is at this point that I would like to applaud Uganda AIDS Commission for the development and dissemination of the stigma and discrimination policy guidelines. We really appreciate. Thank you very much. However, it also shocks us to read in papers, like for most of you who read the monitor of the 10th this month, if you can search for it, it is unacceptable during this time. It is against this background that as a community of people living with HIV, we would like to propose a number of interventions as each takes responsibility to end AIDS by 2030. Increase domestic funding, operationalize the AIDS Trust Fund and the health insurance. We really appreciate the programs and the plans. However, if these can be operationalized, the better. Have an enabling legal environment that supports community members to freely, openly, and open up and participate in the HIV response. The laws that criminalize HIV communities, such as the Kcas, will be counterproductive. Nationwide rollout of treatment literacy among the people living with HIV. Each must understand the disease being managed, the do's and the don'ts, if we are to have continuity in care and viral load suppression. Implementation and monitoring of the HIV stigma and discrimination policy guidelines up to the lowest level, using various ways of involving multi-sectoral players. And besides, stigma reduction interventions must be specifically funded based on what has worked with minimal resources. We really call upon Uganda AIDS Commission to leverage on the communities of people living with HIV who are in the different districts and at different levels to engage in cascading down the stigma and discrimination policy guidelines. Meaningful representation and involvement of people living with HIV in planning, implementation, and monitoring of all programs pertaining the lives of people living with HIV in the spirit of nothing for us without us. Let us work with people living with HIV leaders at community, subnational, and national levels. Mitigate stockout of drugs and essential commodities, not only for HIV, but also comorbidities, and integration of services is the way to go. Need support to strengthen our PLHIV structures at all levels. National, district, sub-county structures should be engaged or strengthened. We are grateful to Uganda AIDS Commission for the opportunity provided to people living with HIV, and we believe that working together, we shall end AIDS by 2030 as a public health threat. We call upon development partners and agencies to fully support our government in this noble cause for the betterment of our lives. As a community, we are ready to take the mantle and work with all of you. At 20 years of NAFOFANU's existence, our theme is no surrender until HIV and AIDS is history. Together for a positive difference for God and my country.
Thank you so much, Raymond, for that presentation or a statement from the people living with HIV. Nothing for us without us. A meaningful representation. how I wish everyone would know that there is no person who can tell a story better than the person that has experience of that very story. So when people living with HIV and AIDS come here and give a statement, we need to pick from what they've told us, and as we program and strategize, we know how to work with them. 1.4 million people living with HIV in this country is not a small number. So me and you, our responsibility is we need to ensure that we do not add on the population of the people living with HIV. How we are going to do it is the reason why we are here, to listen from different people and forge a way out together. At this moment, I want to call upon Uganda National Students Association President, Mr. Bill Clinton Nasasira, to come and give a statement by young people as our UNFPA country representative prepares to come next. Mr. Nasasira is in the house? Is being represented by another young person. I was calling a gentleman and I'm seeing a lady coming in. That's why I was asking whether he's in the house. But you're welcome. Please take the mic and give your statement.
Thank you so much. Mr. Bill Clinton Nasasira, the president of Uganda National Students Association, is in Gulu, interacting with guild leaders and other student leaders at the Pan-African Symposium that is at Gulu University. That is why yours faithfully, the speaker, is here to deliver as said. I will stand on the agenda as earlier on aligned. My name is Chiyuba Jenna. I am a fourth-year student of law at the Islamic University in Uganda and serving as the Secretary for Women Affairs at Uganda National Students Association. And by the grace of God, I am serving as the Speaker currently. Uganda National Students Association is an umbrella that advocates for education, mainly among students in post-primary level of education. Post-primary including secondary schools, certificate and diploma awarding institutions, and as well universities that are recognized by the Ministry of Education and the National Council for Higher Education, respectively. We take this opportunity to thank the Office of the President and the Government of Uganda for supporting Uganda National Students Association since 1988, when it was recognized as Uganda National Students Association from former National Unity for Students. The government of Uganda setting up the Uganda AIDS Commission has been very important to us, the students, because Uganda AIDS Commission has been a very great partner with UNSA, Uganda National Students. We just abbreviate and call it UNSA to make it look better, you know, and shorter. Exactly. So we want to thank Uganda AIDS Commission for always supporting us. We know that they have our back every time. We have engaged in debates with students, and this year we had a debate that we had over 128 schools engaging in a debate tournament with 5 representatives from each school. So what we are doing the most is advocacy and expanding awareness. So, and that we were very much supported by the Uganda AIDS Commission through funding, through giving us material and other resources. And I want to thank the director for making it happen. Sharing information selflessly about HIV/AIDS is what is going to help us as the youth, as the parents of tomorrow and the parents of now, so that we can curb this and achieve the vision of 2030 of curbing new infections, having zero mother-child transmissions, those are the new infections, having zero stigma among us on non-discrimination, and also having zero AIDS-related deaths, because those are the main things we are really looking forward, and we only have 7 years. Ladies and gentlemen, we each have a role to play in achieving this by 2030. Those are the 7 years we are having. So I call upon the mothers in the house that to just be cautious about the fathers we are getting for our children, and the fathers also be cautious about the mothers we are getting. Not in such a way that you should discriminate each other, but just understanding the status of your partner, making sure that as a child, she doesn't be affected by what your relationship was before they were brought to this world. Because we are seeing a lot of children are coming into the world and they're already infected, yet we can curb that, and so we can prevent new infections. My message specifically is to mainly the youths to get informed, get information about AIDS, because we always get shocked every single time we interact with Uganda AIDS Commission. There is something new that we learn as students, like every single time. And today I only had condom use, and then today they told us about another device for women. Then they talked about the injection. So I mean, there is need for us, the youths, to go an extra mile of learning what other options do we have other than condom use. Because I mean, condoms mostly are being set as a main issue because female condoms are really expensive and we don't have them at universities, yet people are sexually active even when we advocate for abstinence. So, but then we have other options. So I think the youths, we need to learn more about other options, maybe other than condom use, and the importance of having our lives. And for my female that I represent at the students level, I just pray that we learn how to work hard so we do not just get distracted by simple things that can cost us our lives. And also to use protection, we practice safe sex. We get tested to know our status so that we can try to keep record on whatever is happening right now. To also break the stigma, do not stigmatize someone, because I mean, AIDS is not the end of life, People have lived with AIDS. We have Dr. Watiti, I don't know if he's still around, Professor Watiti. He has been speaking to a lot of youths, and he has not died yet, he has lived for many years. So I mean, why are you stigmatizing someone? They might even actually become your bosses, and then you just made them feel less of themselves. So to also spread awareness, and that's what Uganda National Students Association is doing. I also implore the youths to draw a line between recklessness and courage. We have taken everything to just be trying out everything, and we are calling it courage, yet it's being reckless on our lives. So the men and the women, especially the youths, let us draw a line between recklessness and courage. They are way different, but then we are carrying them as if they are the same things, and we are not caring about what the future has for us and what these statistics mean to us as a country. I also look at religious and cultural leaders. When we look at Mbarara statistics, Mbarara district is the rural part of Mbarara, which means maybe we would not be getting those issues, but the government and operational bodies that are looking at AIDS response are more concentrated in the town areas because that's where most population is. However, we are neglecting the villages, and since us, the religious leaders and cultural leaders, are there in the villages, how about we take it upon ourselves to be talking about AIDS in church regularly? I mean, it's not a big deal to just create a session after church and you just talk about the youths, their relationship with AIDS and relationship with each other. I believe that would be very significant to us. The Uganda National Students Association also recommends Uganda AIDS Commission to increase the information they put out for us in public. For example, now it was very much known that Mbarara has an over 14% prevalence at this point. But then we have not gotten something from Uganda AIDS Commission telling us that it is okay, they are there, but then we can reduce the new infections that are supposed to be coming in. So, and then just to recognize the fact that currently social media is it's too much spread, and there is need for us to utilize social media to just make youths the ones that are infected and those that are not infected, to just be aware of what is happening, to give us hope. I mean, how about such a message like AIDS is not the end of life, signed by Uganda AIDS Commission, and it's out there? Because there are many memes moving around. Just, for example, there are memes that threaten us to go and check, and Uganda and AIDS response teams are not addressing that. So I implore everyone that is responding to the status quo of AIDS to utilize social media. How about us who are here today just talking about AIDS, just today on all of us, our social media accounts? I mean, you know, it could create a difference because some other person is just looking at your media and following you and seeing what you are doing. For us that are infected, we need not to aggravate the situation by spreading. Let us take caution. Maybe if the doctors tell you that you take your medicine on time, kindly adhere to that. Let's take the medication on time. Let's do any other preventions that we can so that we don't spread it to the next person, and also look at the next generation that is coming. Together we can achieve the vision, the presidential initiative of 2030 of 0 new infections, 0 stigma and discrimination, and also 0 AIDS-related cases. For God and my country, we stand for liberation as the Uganda National Students Association. Thank you.
Another round of applause for Jemima, who has represented well her president. We want to thank you, young people. Messaging. Uganda AIDS Commission, you're the custodians of messages of HIV and AIDS in this country. As a person, even before I joined politics, even before I went to the other side of government, I used to talk about the messages that go out when it comes to HIV and AIDS. So the young person has echoed on it. For example, AIDS is not the end of life as a message out there so that it can reduce on the stigma. People get to know that even when you have HIV, you can still live. You can still achieve your goals. You can still be of hope and use in this country. There is one time when I was still working with one of the NGOs of key populations in this country, and we used to find messages. And one of the messages that used to disturb my head and conscience was, don't give in sex for money. Yet we had sex workers in this country who give in sex for money. And I would be like, if this message is being taken up by a sex worker, how is it going down with this person? Don't give in sex for money, yet there is someone who is selling sex. Messaging, Uganda AIDS Commission, there is a lot to do if we are to put our hands together to fight HIV in this country. As we continue, I can sense the chief guest is arriving, and I will take this opportunity to welcome her as she comes in and to give you a brief of how the program is going to continue once she gets in. After she has been ushered in and given her seat, we will all welcome her and raise up for the national anthems. Both Ugandan anthem, East African anthem, and then the HIV AIDS anthem by Fire Rutaya, the famous song, Today is me, tomorrow is someone else. So I can see she is being briefed by the directors at Uganda AIDS Commission. But as she comes in, I also want to continue reflecting on what the youth has talked about. Honorable Minister, you're welcome. I think we can all rise to welcome her as she's being ushered in. Honorable Minister of Presidency, you're welcome. I want to take this opportunity to welcome you to this second National HIV and AIDS Symposium that is taking place here. You're welcome. My Honorable Minister, you're welcome.
Thank you, dear.
We shall all keep standing, and I would request the DJ to pray anthems in the ascending order. Thank you so much. We can remain standing and we have a word of prayer.
Bismillah. Let's humble in prayer. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والأصل إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر. Amen.
Thank you so much once again. Thank you so much. Honorable Minister, you're welcome. You found us in the middle of the afternoon session, and we are glad to have you here. And I want to take this opportunity to introduce some of the people that we have with us here. I will introduce the DOD Country Director, Mr. Was. We also have the Peace Corps Country Director, Ms. Lily. PEPFAR Country Coordinator, Ms. Mary. Peace Corps staff and volunteers who are here. We also have Dr. Dennis Bwanika, U.S. Mission. Then we have Ministry of Health officials. Ministry of Health officials who are here. Even when you don't stand up, you can raise your arms so that the minister get to know the ministry officials that are here. We have members of civil society organizations. We have young people who are in this house, especially those from the 7 universities that are represented here. We have people from private sector. We have people from the network of people living with HIV and AIDS. We also have people from research institutions. And we're also blessed to have UNFPA country representative present here. You're welcome. For those that have not introduced, maybe have not gotten your names here as we go on, I will continue to introduce you. Honorable Minister, without wasting any moment, I'm going to invite Dr. Bagambe Vincent, who is going to give key highlights from GAR report. Dr. Bagambe, you're welcome.
Thank you very much. The Master of Ceremonies, Honorable Margaret Rwebyambu, who is also a member of the Parliamentary HIV Committee, HIV and other social-related affairs. Honorable Minister Mire Babiria Babalanda, Minister in charge for the presidency, His Excellency the Ambassador of the United States, the chairperson of the AIDS Development Partners Group, and beyond that, ladies and gentlemen, allow me to stand on the protocol that our dear session chair has established and brief the minister. So, ladies and gentlemen, each one in your own capacity, you are all most welcome, and thank you for coming to this session. Honorable Minister, before you came in, we have received 2 presentations which were relating to this closing session. We had a presentation from a representative of the persons living with HIV and AIDS who appreciated the services that the government is offering to them, but also requested that we should eliminate all the barriers to accessibility to services to make sure that all people living with HIV and AIDS access services as one way of taking us close to ending AIDS by 2030. As we were entering, Honorable Minister, we also received a presentation by a representative of the young persons, who actually is the same person who gave us the opening prayer. And for the young people again, they appreciated Uganda AIDS Commission's engagement with them. We've been engaging them, Honorable Minister, in organizing debates through which they are able to sensitize and advocate for HIV prevention amongst their friends. I think the challenge she raised was how we can address the area and be able to take HIV prevention messages to the young people in a modern way. I will now give a few highlights of the report that we have presented at today's symposium. Honorable Minister, Honorable His Excellency the Ambassador, and dear friends, we have discussed this report using several approaches. We had a presentation of the highlights of the report, but also we had a panel discussion here by different categories of people. The beneficiaries of the services, the service providers, the researchers, including, we were honored, Honorable Minister, to have first physician, the first doctor in Rakai to identify HIV/AIDS patients in 1982. He was here also to share his experience. So in this report, we are noting that there is overall a decline in the incidence, the number of new HIV infections, if you put them per average population per year. However, because we are also getting young people converting or growing into old age, this is not helping us to see the prevalence going down. So the HIV prevalence is still at 5.1. In 2020, when we developed this plan, the HIV prevalence was at 5.5%. So it has reduced to 5.1. But the other indicators that we are looking at more keenly is the number of new HIV infections. And Honorable Minister, I am reporting that the number of new HIV infections is not reducing as we would want. It's reducing, and that's progress, but we can say we have not yet reached the level when we can call it success. Because whereas we want to see new HIV infections reduced to 10,000 per year by 2025, we are still seeing 51,000 new HIV infections. We are also noting that AIDS-related deaths have stagnated in the last 3 years at around 17,000 Ugandans dying per year, which translates to about 300 Ugandans dying each day. So there is a stagnation in that aspect as well. Honorable Minister, in terms of coverage with antiretroviral drugs, we set out to attain 95, 95, 95, meaning that 95% of people living with HIV and AIDS know their HIV status by 2025, and that of those who know their HIV status, 95% have been put on treatment, and that of those who are on treatment, 95% are virally suppressed. Honorable Minister, this report shows that we are not at 95, 95, 95. we are at 90, 94, 94. Meaning that 90% of Ugandans are, who are living with HIV know that they have it, they have tested, and they are aware. And those who are aware, then 94% have been started on treatment, and 94% of those on treatment are virally suppressed. So the gap is on the first 90. We seem still not to be able to get people. The 10% is still elusive. We need to get them if we are going to end AIDS by 2030. But more importantly, Honorable Minister, is that when you look at these figures and categorize them by young people and adults, we seem to be leaving behind the young people. Because the young people, for those who know, they tested and know their status, they are at about 80%. And also those who are adhering to their medication and therefore benefiting from the medication are low. We have made progress. We continue to identify and test more people. 6.8 million Ugandans tested last year, and of those 142,000 tested HIV positive. And 88% of those who tested HIV positive were put on treatment. We are able to achieve this, Honorable Minister, because of the coordination and collaboration we have with all our stakeholders, as can be witnessed by the representation in this hall. As Uganda AIDS Commission, we have revitalized the engagement with stakeholders, both at the national and at the subnational levels. We are engaging cultural institutions to reach, through them to reach the people. We have engaged and are continuing to engage with higher institutions of learning, as you heard from the testimony of the young person. But also, Honorable Minister, we are engaging through the leaders. As you are aware, we've been engaging the resident district commissioners, the resident city commissioners, and their deputies to also be able to disseminate approved HIV prevention messages through their radio communication. Honorable Minister, we have also made great strides on HIV and AIDS mainstreaming in the government sectors. We have seen that 80% of the government institutions now are able to plan for HIV interventions. They allocate 0.1% of their budget towards HIV interventions, and most of them are submitting their reports to Uganda AIDS Commission. And last but not least, we are seeing that government of Uganda's contribution towards the HIV response is sluggishly increasing. Last year, government of Uganda contributed 14% to the national, to the costs of providing HIV services. And this time around, this increased from 320 billion Uganda shillings to 358 billion Uganda shillings, which is equivalent to 14%. So the major gaps, Honorable Minister, and members present, is that we seem to be leaving children and adolescents behind. We have noted that 35% of new HIV infections are occurring in unmarried women. We also note, the report notes that when you go to antenatal care facilities, 43% of women who test HIV positive from there are actually young mothers, less than 24 years of age. If we continue with this, of course, then it means that our dream of reaching 95, 95, 95 and ending AIDS by 2030 may not be realized. We are also seeing increasing proportions of individuals with multiple sexual partners. In terms of behavior, Honorable Minister, people are using less condoms because last year we distributed 141 million condoms as compared to 189 million condoms last year. So fewer condoms were used, and yet studies show that risky sexual behaviors are on the increase. So this needs to be addressed through intensified behavior change communication and messaging to make sure that we leave no one behind and we reach everybody. Honorable Minister, the other big challenge that I want to bring, and there are many challenges, but I'm picking just a few that require your attention. The second big one is the inadequate financing of the HIV response. We are putting people on treatment, and the care and treatment component seems to be fairly funded. But the prevention component of the response is underfunded, and we think that we need to intensify efforts to raise resources domestically to ensure that we are able to disseminate messages. We know that mainstreaming is making a contribution. Our RDCs are making a contribution. The cultural institutions and religious leaders are making a contribution. But all these need concerted efforts and more efforts in order for us to realize, to be able to close the tap and realize the reduction in new HIV infections. Honorable Minister, allow me to end here. This is so far what we've been able to compile in the report. We have a team of rapporteurs who will compile the report from, maybe I should have briefed the Honorable Minister that in addition to this big tent, we have breakout sessions and we are discussing scientific papers. So we have scientists who are also advising on the best way to prevent or to manage HIV and AIDS in Uganda. So all this will be compiled into one comprehensive report, which will be brought to your office. I thank you, Honorable Minister, for coming, and I thank you for coming to host all these people that are with us here. Thank you.
Another round of applause for Dr. Bagambe Vincent, who has ably represented the Director General Uganda AIDS Commission, and you've all heard the statistics and how he has really given us what Uganda AIDS Commission is doing. It remains a fact that ending HIV is a responsibility for all of us. Though the same is my responsibility towards ending AIDS by 2030, I think the mantle is supposed to be carried by all of us if we are to hit the target. At this moment, without wasting any minute, allow me to invite the UNFPA country representative who is going to give us the keynote address on ending the HIV vulnerability dilemma among adolescent girls and young women, and what we need to do better than what we've been doing. Sir, you're welcome.
Thank you. Honorable Babalanda, Minister in charge of the Presidency. Honorable Margaret Aibare, Chair of the Session, Member of Parliament. Chairman of the Uganda AIDS Commission, Dr. Eddie Sifuluya. Representing the Director General of the Uganda AIDS Commission, Dr. Vincent Bagambe. His Excellency Ambassador William Pope, Ambassador of the United States of America to Uganda, heads of agencies here present, senior government officials here present, bilateral and multilateral partners here present, civil society partners, a network of people living with HIV, UN agencies here present, implementing partners, ladies and gentlemen, all protocols observed. Good afternoon. As UNFPA is the chair of the AIDS Development Partners Group, I'm very pleased to be here, of course, with all of you today to deliver a keynote address on behalf of the development partners on our collective responsibility to end the HIV vulnerability dilemma among adolescent girls and young women. It goes without saying that Uganda has long been a leader in the fight against HIV, with significant and remarkable success, both globally and regionally. This certainly would not have been possible without the leadership of the Ministry of Health and the Uganda AIDS Commission, and the indispensable support from PEPFAR, Global Fund, the private sector, the UN family implementing partners, civil society, and the communities themselves. The speakers before me have all laid out the progress we have made thus far, the challenges in front of us, the recommendations to move forward with such clarity and knowledge. So I will certainly not be repeating any of the things said, but just allow me to bring to your attention to one of the most vulnerable populations that is affected by the HIV/AIDS epidemic here in Uganda, and explain why this vulnerability persists and what we can do collectively to address this issue. In 2022, almost 20,000 out of the 52,000 new HIV infections were among young people ages 15 to 24. And out of the 20,000 new HIV infections, 15,000 of them were among adolescent girls and young women. So I repeat, 15,000 out of the 20,000 were among adolescent girls and young women. This translates to 4 out of 5 HIV infections occurring among the adolescent girls and young women age group of 15 to 24. Young people are certainly looking at us and putting us to task to address this scourge. They're asking us to leverage on each other's strengths, coordinate our efforts, be deliberate and consistent in our approach, use the latest innovations, and recommit ourselves to tackling adolescent girls and young women's vulnerabilities holistically and comprehensively. You asked what we need to do better. We, as the AIDS Development Partners Group, believe that HIV prevention efforts from both a biomedical and structural perspective need to address persistent gender inequalities urgently. Honorable Minister, Excellencies, ladies and gentlemen, we have a narrowing window of opportunity to end AIDS for all adolescent girls and young women by 2030. 4 decades of game-changing scientific breakthroughs and program interventions have given us the knowledge we need to accomplish this. Allow me to share some thoughts on ways to address these gaps. Reducing teenage pregnancies. In Uganda, the weighted pregnancy prevalence among adolescent girls and young women aged 15 to 19 years is alarmingly high and has stagnated at 24% for the last 20 years, as per the recent DHS also indicates. In 2023, 250 children aged below 15 years got pregnant weekly. This is unacceptable. We must all work together to address this urgently. The unmet need for family planning stands at 21%. Adolescents and young people need access to different options of contraceptives and need the services to be targeted and accessible. Similarly, adolescents aged 15 to 16 years have an early sexual debut, with 1 in every 10 girls, around 20%, engaging in sexual intercourse by 15 years of age. We need to remove the barriers that continue to make this age group vulnerable and provide adolescent-friendly services to increase access to existing sexual and reproductive health services, including HIV. Education is one of the most important tools that we can use to empower girls and young women. It helps them learn about their rights, develop the skills they need to succeed in life, and to protect themselves, of course, from harmful practices such as child marriage, HIV infection, and other STIs, as well as FGM. Evidence from other countries show that if girls are able to stay and finish secondary school, their risk of getting HIV can be reduced by up to 50%. We know enough to say that harmful sociocultural practices disproportionately and continuously make young women and adolescent girls more vulnerable to HIV. Traditional norms and customs encouraging early marriage and childbearing are still widely prevalent in Uganda. About 20% of teenagers aged 15 to 19 years are being married or living together with a partner. All these practices are done, unfortunately, in spite of existing laws. We must work together with the government to change the mindset of communities, traditional and religious leaders, and to collectively work towards changing the negative gender norms and other associated negative practices that make young girls vulnerable. We need also to advocate for policy changes towards appropriate and proven solutions that will reduce the number of new HIV infections and AIDS-related deaths, but also, of course, ensure the effective implementation of programmatic interventions. This is absolutely a must. Let us also not forget the knowledge gap among young people and adolescents when it comes to HIV. Comprehensive HIV knowledge among young women aged between 15 and 24 remains low at 56% based on the 2022 DHS. Inadequate knowledge and accompanying poor skills and insufficient resources mean that young women remain unprepared to make safe and healthy decisions regarding their sexual and reproductive health. So let us make sure that the knowledge gap is addressed by providing platforms such as social media, for instance, to raise awareness and improve comprehensive knowledge about HIV and sexual and reproductive health. Of course, we must also take advantage of new technologies. Everyone here, including communities, should take the responsibility of advocating for the use of new technologies to be rolled out without disparity and discrimination, such as the PrEP injection, which I believe we've discussed earlier, and the vaginal ring. Finally, I briefly touched on the need for an approach that is holistic and multi-sectoral. In this response, we need the community, not only to succeed, but also to sustain the response and end the AIDS epidemic here in Uganda. The community and constituency of young women and adolescent girls and young people in general are an integral part of the movement in resolving some of the persistent challenges that continue to make them vulnerable. Young people have spoken through their various platforms, including the Uganda National Young People's Association and the Youth Situation Analysis report recently, on how they want to be involved in a meaningful manner. Overall, young people are calling for increased involvement in the design of interventions that are meant for them, right from program design to implementation and monitoring. Youth involvement will increase the level of ownership amongst the youth, as well as transparency and success. Uganda has much experience working with communities to manage significant health challenges, including pandemics. We have seen it with COVID and with Ebola. So it is indeed vital that we empower communities, including young women-led organizations, to take a lead in addressing these same vulnerabilities of their communities. This year's World AIDS Day calls upon putting communities in the lead. The theme emphasizes that we can end AIDS as a public health threat by 2030, but only if communities are fully included and are sufficiently funded to lead the way. It highlights how underfunding and harmful barriers are holding back the life-saving work of these communities and obstructing the end to AIDS. Excellencies, ladies and gentlemen, as I conclude, let me also express my immense gratitude for the progress made thus far, which we should not lose sight of. Special thanks to the leadership of the government of Uganda, who have tirelessly worked with partners in the planning and execution of the HIV response in the country. I would also like to thank the frontline workers who have made it possible to have these achievements thus far. And finally, a round of applause, please. And finally, let me extend my sincere appreciation to the development partners for the support that has collectively contributed to the government-led efforts to lay ground for the targets of ending HIV/AIDS as a public health threat by 2030 and create an AIDS-free Uganda. Together, we have the power to empower adolescent girls and young women. By working together, we can provide them with the skills and knowledge they need to succeed, advocate for what works, and be informed by the data to scale up our successful efforts efficiently. Together, we can make a real difference in tackling the vulnerability of adolescent girls and young women and building a better future for all. I thank you all and look forward to a fruitful symposium. Thank you very much.
Thank you so much, our UNFPA country representative, for this elaborate, keynote address. Young people are looking up to us. We need to reduce teenage pregnancies. We need to provide adolescent-friendly services. And we also need to work hard and ensure that we change people's perceptions as far as HIV is concerned. We are responsible for the policies and laws in this country, but I want to say this, that even if we put beautiful laws and policies in place, the most laws begin with families, clans, communities, and societies. We need to work hard and change people's perceptions if we are to end HIV by 2030. I want to take this singular honor and opportunity to invite His Excellency William Pope, the US Ambassador to Uganda, to come here and give his statement. You're welcome, Your Excellency.
Honorable Minister of the Presidency, honorable ministers present, and honorable members of Parliament, representatives, all of the Ugandan government, ambassadors, heads of missions and development partners, Director General of the Uganda AIDS Commission, religious, cultural, private sector, and civil society leaders, distinguished guests, ladies and gentlemen, all protocols observed. Good afternoon. I am honored to attend my first National HIV Symposium here in Uganda. and to have the opportunity to highlight the tremendous and lasting impact of our cooperation together, particularly through the PEPFAR program, which is celebrating 20 years since its creation. Among all U.S. government programs, PEPFAR is one of the clearest demonstrations of the power of drawing scholars, researchers, scientists, engineers, and others together to find bold, innovative, and audacious solutions to big challenges. The world-renowned musical artist and activist, Bono, who has been an important voice in the global fight against HIV and AIDS, noted that PEPFAR is, quote, the most eloquent expression of American values anyone can think of in recent times, the most brilliant outpouring of American ingenuity. Now, of course, we have much more work to do through PEPFAR and through our overall cooperation in fighting HIV and AIDS. But many of you will remember the early days when HIV/AIDS was actually a death sentence for virtually every person that tested positive. Fortunately, over the last 20 years, together with partners around the world, PEPFAR has saved more than 25 million lives and dramatically improved the health outcomes in more than 55 participating countries. Here in Uganda, of course, the theme of this year's symposium is mobilizing everyone to take collective responsibility while ensuring social accountability if we are to truly end HIV/AIDS as a public health threat by 2030. And in this spirit, it is important that we focus on equity and accountability as vital components to reach epidemic control in 2030. We have made great strides, but over the years we've also identified a number of challenges and commitments that we need to make to overcome those challenges. We've heard about many of those challenges today. And one of the challenges also is including that it is essential to add equity to the pillars of accountability, transparency, impact that are guiding us in our efforts against HIV and ensuring that treatment programs reach everyone. In particular, laws and practices that discriminate against anyone that is seeking health services work against our efforts. We must prioritize equity if we want to eliminate the persistent inequalities experienced by children, adolescent girls, young women, and key population groups that are at increased risk for contracting HIV. As many of you know, the first national HIV/AIDS control program in Africa began here in 1986, and Uganda was the first African country to begin to reverse its HIV epidemic. Over the past decade, the number of people contracting HIV has fallen significantly, but Uganda's HIV infection rate is still one of the highest in the world. Sadly, HIV infections are not declining as rapidly among adolescents and key populations as among other age groups and other population groups. Girls and young women remain particularly disproportionately impacted by HIV, with 2/3 of adolescents diagnosed with HIV being girls. HIV prevalence among sex workers is estimated also to be very high at over 35%, as well as 14% among men who have sex with men, as well as 35% among fishing communities, among other vulnerable populations. Meanwhile, national data indicate that at the end of September 2023, over 1.4 million people living with HIV were on treatment, and 1.16 million people had confirmed suppressed viral loads. That is the power of PEPFAR and other programs and the collaboration that we have to save lives. At the same time, we must continue to partner with sectorial agencies, organizations, and all Ugandans to focus attention on the areas where gaps do still exist. As the theme of this event indicates, equitably addressing every person who requires health services is key if we are to sustain the progress that we've already made. Evidence shows that laws and policies such as the criminalization of HIV transmission and same-sex relationships hamper HIV response and people's access to stigma-free sexual and reproductive health services. Instead, information-based efforts, including age-appropriate sex education and targeted HIV prevention campaigns, can reduce HIV infections, as can also addressing domestic partner violence, which remains a significant social driver of HIV as well. Issues discussed over the next few days in this symposium should not only demonstrate solidarity and commitment to end HIV/AIDS related deaths by 2030, but also a commitment to act, make changes, and advocate for what we need. We can do many things. We can reach the global 95-95-95 treatment targets for all ages, genders, and population groups. We can also close equity gaps for priority populations, including adolescent girls and young women, key populations, and children. We can also reduce new HIV infections dramatically through effective prevention and treatment in support of UN/AIDS targets. As we think about the people living with HIV and the young people here today in particular, I would like to reinforce what matters most is not the numbers only, but rather the names, not the statistics, but the stories, the lives forever altered for the better, the chapters rewritten, and the futures restored because of HIV treatment. The tools provided by PEPFAR and other programs of cooperation and our partners have helped to prevent, treat, and control this disease. We should be proud of the tremendous progress we have achieved, but again, our work is not finished. New data from UN/AIDS on the global HIV response reveals that years of the COVID-19 pandemic and other global crises have slowed the progress in fighting HIV and AIDS in recent years. Millions of lives are at risk as a result. In addition, because of stigma, discrimination, and other structural factors, certain populations and geographic areas continue to bear most of the burden of this disease. Thus, we remain, as the United States, deeply committed to ending HIV everywhere by engaging and empowering communities and ensuring that our programs, research, and policies are informed by the voices of the people most impacted by HIV. Our work on HIV/AIDS also extends to supporting organizations and institutions in the broader health space. Why? Because the HIV epidemic does not exist in a vacuum. Ugandans, including people living with HIV and AIDS, have health needs beyond HIV prevention and treatment. And we have seen that in the battle against the most recent pandemic of COVID-19, the platforms built for PEPFAR were critical for fighting it and for fighting Ebola. This is why PEPFAR has worked to build health systems equipped to adapt to the threats of HIV/AIDS, but also to prepare for the public health concerns yet to come. Now, I am sure that you all are aware that after the implementation of the Anti-Homosexuality Act in May of this year, the U.S. government paused the PEPFAR Country Operational Plan, or COP 2023. That approval process was paused in order to review and better understand the potential implications of this legislation. And the United States remains profoundly concerned about the AHA and any instance of its implementation. As stated by President Biden in May, we will continue to call for the immediate repeal of this legislation. However, ultimately, the COP 2023 was approved to move forward to ensure life-saving assistance continues to benefit all people in Uganda. However, this assistance will advance with restrictions on certain direct funding to the government of Uganda, as well as limitations due to the concerns about the harm of the AHA on human rights and HIV response. The new restrictions are not intended to impact service delivery, and the U.S. will continue to be committed to serving all people in Uganda without discrimination. In alignment with U.S. law and efforts by the U.S. government to prevent discrimination based on race, religion, gender identity, or sexual orientation, we will continue to ensure that principles of non-discrimination are upheld in all PEPFAR programs. In accordance with these requirements, we seek to provide services to all populations and maintain equitable access for all in the fight against HIV. Finally, to better expand access to HIV prevention, treatment, care, and interventions, PEPFAR has reimagined its strategic direction based on extensive partner and stakeholder input to focus in the following areas. First, broadening HIV/AIDS conversation beyond the health sector and engage directly with national HIV/AIDS planning and coordination structures. Secondly, to strengthen national health systems for HIV and related health security capabilities, to promote public health security and responsiveness for all. To achieve this,
if we are to fight HIV in this country, it might not be your take home, but I believe it will be my take home as a member of parliament. And without more ado, I want to take the opportunity to invite the chairman, Uganda AIDS Commission Board, Dr. Eddie Mukoyo, to give his remarks. I thank you.
Thank you very much, Master of Ceremony. Our guest of honor, Honorable Minister for the Presidency, Your Excellency the Ambassador, U.S. Ambassador to Uganda, the Chairperson of the UN AIDS Development Partners, PEPFAR, and the support we enjoy from U.S. government, the Honorable Member of Parliament who has been with us as the Master of Ceremony for this session. Let's give a round of applause, first of all, to the Honorable Minister who made it in time, who made sure that he's here. But you people don't know how to clap. Let me show you. Asante sana. Because it was a long, tall order for her to be here. We are very grateful, Honorable Minister. And let's also give the same applause to His Excellency, the Ambassador. This is his first time to come to attend Uganda the AIDS Commission function. Asante sana. Then, of course, the AIDS Development Partner Chairperson and PEPFAR, we are most grateful. Asante sana. I know that we've, in the interest of time, I'll not go into my remarks, but thank most sincerely our guest of honor for making it and officiating at this opening ceremony for the symposium. Allow me just to hand over this mic to the Honorable Member of Parliament, who is also a member of the HIV/AIDS Committee, representing the chairperson. You're most welcome. Thank you.
Thank you so much, Chairperson Board, Uganda AIDS Commission. On the program, he was supposed to invite the guest of honor, but he has dodged it. But I want to take this opportunity to first of all thank you, my Honorable Minister, for taking out time on your busy schedule to come and grace this occasion. It's not, we can't take it for granted. I know how busy you are. And I want also to thank the Honorable Minister in front of you, because I sit on the committee of HIV and AIDS in Parliament, and time in, time out, we call her to the committee to speak about HIV, AIDS, and related matters. And I want to tell you that she has ably represented the Uganda AIDS Commission on matters of HIV in this country. I want to thank you sincerely before this congregation. And I want to take this opportunity to invite you to come and give your speech and officially open this second National HIV and AIDS Symposium. You're welcome.
Thank you, my sister, Honorable Member of Parliament from Mbarara District, Honorable Ayebale Margaret. Your Excellency, Mr. William Pope, Ambassador of the United States to Uganda, Honorable Members of Parliament present, the Chairperson of the AIDS Development Patterns Group, and the representatives of AIDS Development Patterns here present, representatives of implementing patterns, scientists and clinicians, representatives of people living with HIV, representatives of religious and cultural leaders, representatives of local government leaders, representatives of civil society organizations present, colleagues from ministries, departments, and agencies present, representatives of the media fraternity, my colleague, Honorable Margaret Ayebale, the session chair, and Honorable Member of Parliament, Mbarara, Uganda AIDS commissioners and staff, invited guests, distinguished delegates, friends, ladies, and gentlemen, good afternoon. My name is Babidi Emile Babalanda. By the grace of God, I'm the minister in charge of presidency. I bring you greetings from His Excellency, the President of the Republic of Uganda, and National Chairman of the mighty party, who has just arrived from his official state duties, retired General Yoweri Kaguta Museveni. More greetings from Mama, the First Lady, and Minister of Education and Sports, Mama Janet Kataha Museveni. It is with great honor and pleasure to be with you today at this great event which brings together scientists, programmers, development patterns, civil society, the private sector, and the government representatives to give account to the Wananchi about the status and progress of implementation of the HIV response. I know that the scientists are here to exchange wonderful research, ideas, program innovations, and how best to solve the program challenges, how to improve treatment outcomes as we strive for a Uganda free of AIDS and its effects by 2030. I am delighted to be a part of this important gathering. I would like to thank the organizers for giving me the opportunity to share a few thoughts with you as we begin our work here together. Ladies and gentlemen, allow me to remind you that His Excellency, the President of the Republic of Uganda, made a promise to the people through the Presidential Fast Track Initiative to end AIDS as public health threat by 2030. As I stand here today, the prospect of a Uganda with zero new HIV infections has never been as real as it is now. Time-proven social behavioral approaches like abstinence and being faithful, combined with the new tools and discoveries like use of condoms, like what my colleagues have been mentioning on it, safe male circumcision, and ARVs are providing people with a real chance of protecting themselves, hence preventing HIV transmission, or where already infected, a chance to live near normal lives. All of us present here today have a role to play in ensuring that the President's initiative and the people's aspirations are realized. Fellow Ugandans, there is much to celebrate about in this fight against HIV and AIDS. New HIV infections have declined by 35%. Elimination of HIV transmission from infected mothers to their newborns is on the horizon, and retroviral therapy is changing the prevention landscape. allowing people to safeguard their health and prevent HIV transmission. At the same time, laboratory tests to diagnose HIV and to monitor its progression can be accessed anywhere in Uganda. Ladies and gentlemen, despite these accomplishments, there are many reasons for concern about whether the Presidential Fast Track Initiative goals will be achieved. The number of new HIV infections in Uganda is still unacceptably high. In fact, new HIV infections are resurgent in some parts of the country and some populations, particularly young people. Every new HIV infection is one too many, and the current record of 52,000 new HIV infections in a year is simply unacceptable, especially when we have the science to prevent them and means of implementation that are simple and cost-effective. Friends, HIV care and treatment is expensive. We can't afford it in the long run as a country. We have no choice but to work harder to prevent any new HIV infections. The theme for this year's symposium is My Responsibility Towards Ending AIDS by 2030. Indeed, it will take all sectors of all societies, public and private, working together to achieve the goal of ending AIDS as a public health threat in Uganda by 2030. His Excellency the President has made his part. Government and the donor friends have done their part. But without each individual taking their responsibility to protect themselves or to seek for care, we shall not end this epidemic. I would like to thank all the stakeholders for making your contributions using the multi-sectoral approach. Uganda was the pioneer of this approach, and other countries learned it from us. Let us continue using this approach to provide the services, but also to reach out to the people to take personal responsibility for their health. It is certainly true that over the last few years, we have made great progress in HIV and AIDS care and treatment. But the sad truth is that these new HIV infections every year make our hope of ending AIDS by 2030 fade away. The cost of providing services cannot keep increasing, straining our economy even more. Clearly, we have much more work to do if we are to achieve the ambitious goals in the Presidential Fast Track Initiative. I should also add that HIV-related stigma and discrimination, as well as gender-based violence, continue to fuel this pandemic and drastically hamper our prevention efforts at all levels. We must address this pandemic with all its complex challenges if we are to slow the high numbers of new infections and provide care and support for the millions of people already living with HIV and AIDS. The government of Uganda has, since the outbreak of the HIV epidemic, recognized its role as a leader in this fight, and we will continue to actively support all interventions aimed at ending inequalities among adolescents, girls, and young women and boys, and to work to enhance our efforts in the battle against AIDS domestically. To make the vision of ending AIDS a reality, we must all work together. The government ministries, departments and agencies, local governments, development partners, the private sector, people living with HIV, religious and cultural leaders, civil society organizations, the media fraternity, and academia. It is everyone's responsibility to contribute to this fight against the greatest public health crisis in centuries. And finally, we cannot win the battle against AIDS unless we deal with the best weaknesses of poverty and gender inequalities. Access to basic education for girls is in fact AIDS prevention. Access to microcredit loans and opportunities for women is in fact AIDS prevention. The list goes on and on. If we are going to be successful, we must ensure that we are not only pushing standalone AIDS programs, but also are including an HIV and AIDS component in each and every one of these efforts as well. We have clearly laid this foundation with the success of mainstreaming HIV in all government development programs. I challenge the non-government organizations in Uganda to also mainstream HIV in your programs. Last but not least, ladies and gentlemen, this symposium is a great opportunity to dialogue and to inspire collective action. May we all seize this moment to learn from each other, build lasting partnerships, and take the actions so desperately needed in our shared fight against HIV and AIDS. As the minister directly supervising the coordination of the HIV response, I wait to receive a full report with clear, actionable recommendations. I commend all our partners for standing to support the AIDS response in Uganda. Your contribution is making a lot of impact in the different categories of our target groups, and for this, we thank you very much. It's now my honor and privilege, ladies and gentlemen, to declare this second National HIV and AIDS Symposium officially open. Thank you for your kind attention, for God and my country.
Thank you so much. I want to take this opportunity to hand over the microphone to the day's MC, who will, I think, take us in the next program. I thank you so much. Thank you for being with me as I took up the chair of the session this afternoon.
All protocol observed and our distinguished guests, we have come to the conclusion of the first day of the symposium. And in less than a minute, allow me to invite the US government staff to join us here for a photo. Just a minute. The Chairman, Scientific Committee, Dr. Tindieba, the Acting Director General, a representative from the PLHIV Network, young person, and then CSO representative. Kindly join us for a minute because our delegation wants to leave. Chair and the board, Uganda AIDS Commission, PLHIV representative, CSO representative, and then we had Pepper. Yes, the team is here. So all our cameras set because we don't have time. Dr. Dennis, we are also asking you to join. Is the young person here? Thank you. Okay. Yes, cameramen, are we set? 1, 2, 3, and go. I'm not seeing CSO representative, so I'll stand on behalf of CSO. And then, can you please play for us the national anthem as the Honorable State Minister? Yes. In reverse order. Thank you.
Thank you so much, each and everybody. Thank you, Honorable Minister, for gracing this occasion. Thank you, Your Excellency, the Ambassador of the United States to Uganda, our distinguished guests. So as we close the day, we are going to request the guest of honor to go and inspect the activities that are taking place outside of this tent. We have the Fire Retire tent. Maybe your Honorable Minister, if you can go to the Fire Retire tent, and then we have other exhibitors. If you find time, we will appreciate. Okay, the ambassador is.